Committee members? There you go. Every once in a while, our new phone system will just kind of tell us what's going on. I'd like to welcome the committee members both here and on the phone. We have Department of Health staff, members of the public, presenters. We have lots of great people here to this meeting at our Health Research Advisory Committee, and I am Rachel Levine, and I'm the Secretary of Health. So I'd first like to do introductions of people here at the table. Staff and committee members, so please introduce yourself. And Dr. Davis, please start.
Dwight Davis, Penn State College of Medicine.
Penny Harris, Health Research Office.
Magna Patel, Department of Health, Deputy Secretary for Health Innovation.
Sarah Botang, Executive Deputy Health, Department of Health.
Office of Legal Counsel.
Very good. For those other members, who are committee members who are on the phone, let me read your names, otherwise it ends up being a cacophony of sound. Is Dr. Karen Wolf-Feinstein on the phone? You might be muted.
I also know she's traveling.
She's traveling. Okay. Is Dr. Arthur Levine on the phone? All right. Is Dr. Michelle Masucci on the phone?
I am. Good morning.
Donna Gentle O'Donnell on the phone?
Yes, good morning. I'm here, Dr. Levine.
Nice to hear from you.
Thank you.
Is Dr. Michael Parmacek on the phone?
Yep, good morning, everyone.
Good morning. Is Dr. Peter Tombros on the phone?
Yes, good morning.
Very good. So that would give us 1, 2, 3, 4, 5, 6. So we have a quorum? Okay, very good.
Kathy is also here, member.
Senator, how are you?
I am well, and you?
I'm great. It's so wonderful to hear from you. Thank you. Is anyone else on the phone?
Dr. Levine, I want to make sure you caught that I'm here. This is Michelle Masucci.
Oh, excellent. Thank you. We had not heard from Dr. Feinstein and Dr. Arthur Levine.
He'll be calling in a bit later.
He will be calling in. Okay. Very good. So now we're going to do introductions of everybody else that was here. So why don't we start and go around the room, and please tell us your name and then what organization you represent.
Hi, I'm Dr. Deb Kelly. I'm from Penn State University, and I'm the director of the new Center for Structural Oncology.
Wonderful.
Good morning, everyone. I'm Cameron Verano. I'm a faculty member at Penn State and part of the Center for Structural Oncology.
Great. Before you continue, can you hear on the phone? Can you hear the people's our members' public's introduction?
No.
I think that we're gonna have to pull that closer. There you go. And you might need to even. Let's start again.
Good morning, Dr. Deb Kelly, and I'm from Penn State University, and I direct the new Center for Structural Oncology.
Good morning. My name is Cameron Verano, and I'm a faculty member within the Center for Structural Oncology at Penn State.
Thank you.
Dr. Maggie McDonald, Office of Academic Affairs, Health Sciences, University of Pittsburgh.
Johnny Anthony from Penn State.
Michael Smith, good morning, Director of Commonwealth Relations for the University of Pennsylvania.
Good morning. I'm Allison Buttenheim. I'm an Associate Professor of Nursing and Health Policy at the University of Pennsylvania, part of the Center for Health Incentives and Behavioral Economics.
Hi, Penny Christopherson from the Department of Nutritional Sciences at Penn State University.
Hi, I am Santosh Girirajan. I'm an Associate Professor of Genomics, Penn State University.
Good morning, everybody. Ben Daniels with Greenlee Partners.
Marianne Bodai from Weber Associates. Shumi Huang from Penn State Health, Hershey. I'm a neurologist.
Charlie Alcorn, I'm just a private student.
I'm Megan Abbott. I'm the Director of Intergovernmental Affairs at the Department of Health.
Hi, I'm Dr. Mylanda Massart, Department of Family Medicine and Clinical and Translational Science Institute at UPMC and the University of Pittsburgh.
I am Dr. Philip Empey from the Department of Pharmaceutical and Therapeutics at the University of Pittsburgh.
Daniel Hall, Administrative Officer, Department of Health.
Pam Brown, Health Research Office.
Christopher Albright, Administrative Officer, the Health Research Office.
Great. Did I miss anybody? I think we're good. So before we begin, I would like to notify you, as the phone somehow already did, that we are recording this meeting, and we also have a stenographer at the meeting. Thank you for your work. And this will ensure that the minutes are accurately taken and reflect the actions and recommendations made by the committee. I would request that everyone silence their cell phones as much as they can and electronic devices. For committee members and everyone on the phone, please place your phone on mute when you're not talking, but then you got to remember to unmute it if you'd like to talk, and that's what people tend to forget. Please do not put your phone on hold, because then we get your hold music, and as lovely as it is, it makes it difficult. The primary purpose of today's meeting is to review the work of the committee and continue the planning process to establish the health research non-formula priorities for the state fiscal year 2020-2021. We are going to be hearing recommendations from invited speakers. Thank you all for being here. Regarding health research priorities, and to discuss and determine the area of research to be considered for the 2020-2021 state fiscal year priorities. This is a public meeting, and I appreciate the interest of everyone in the audience and those who might have come to observe. I do want to stress that in order to ensure that we have enough time to conclude this business, we do not intend to take public comments at the meeting. So to review our agenda, you can hear my Boston accent come through. Our business for this meeting is to review and approve the minutes of the meeting held on February 11th, 2019. We're going to review the CURE program and give some updates. We will receive the presentations of the topics that were chosen. We have time for the committee members to question the presenters and hear some responses. We will discuss the non-formula funding priority for the 2020-2021 state fiscal year and the next steps. Would any of the other committee members like to add to this agenda? Dr. Davis? Anyone on the phone?
Yes, Dr. Payne, if I could just ask that at some point we go back and first of all, congratulations to your staff for an outstanding job assembling the detailed materials that we got and the historical perspective. If we could also just touch on the Oak Ridge process, that was the conversation that I remember being most relevant in the last meeting.
Yep, that will be when we review the program and give updates. So we will include that, Doctor.
Great, thank you so much.
Sure. So anything else? So our first order of business is to review and approve the minutes of the meeting held on February 11th, 2019. The minutes were available on the SharePoint HRAC member website prior to the meeting, and a copy was provided to the committee members and staff in Harrisburg. If you're making a motion and sending it over the phone, please provide your name first. May I have a motion to accept the minutes?
Yeah, Mr. Chair, I have reviewed the minutes and make a recommendation for approval.
Thank you, Dr. Davis. So I have a motion to accept the minutes from Dr. Dwight Davis here in Harrisburg. Is there a second?
Mike Armitage, second. Either way.
Either way.
Okay. Did you get that? Okay, very good. Is there any discussion? All right. I will now call for a vote. All those in favor say aye. Aye.
Aye.
Are there any opposed? Say nay. Are there any abstentions? Thank you. The minutes are now approved. So our next step is to review the CURE program, such as the priorities, the types of funding, the funding status, and then we'll be doing some updates. So for the CURE program, the formula funding is 70% of the tobacco settlement funds received by the program. The formula funding is set each year for nonprofits, hospitals, and institutions of higher education that conduct research and are eligible based upon the receipt of National Institutes of Health funding over the past 3 years. Non-formula funding is 30% of the tobacco settlement funds received by the program. Identifying non-formula research priorities for the department is the primary task of this committee. Part of this review is used to pay for the vendor who assists the program with peer review of applications and interim and final performance review of completed grants. A committee charter is developed and included as Appendix A for your reference. CURE funding. The state fiscal year 2019-2020 amount currently identified for CURE health funding is $45,774,000. $45,774,000. This amount is an estimate provided to the Department of Health by the Governor's Budget Office. The actual amount of the funds is not known until the check is received in April or May of the following year. Only after this time period can we make payments to the grantees. That's how the system works. The final amount for the state fiscal year 2018-2019 CURE non-formula opioid priority is $11,434,009. Not $8, $9. Again, the final amount of the 2018-2019 CURE non-formula opioid priority is $11,434,009. The amounts available for the state fiscal year 2019 and 2020 CURE non-formula Alzheimer's priority is $11,289,709. To repeat, $11,289,709. The RFA, or the request for application for the Alzheimer priority, is in its final revisions. The goal is to have the RFA posted to the Department of General Services e-marketplace in the next month. When the RFA has been posted, the CURE website, cure.pa.gov, will be updated with the link, and the grant period will start June 1st, 2020. The 3 2018-2019 opioid non-formula grant proposals to receive the award are in the final review process at the department. But all the entities that submitted proposals have been notified of their status regarding the award, meaning the winners have been notified and the non-chosen applications have been notified. And we're hoping to finish that up. On May 19, 2019, an email was sent notifying the committee of the location of the posting of the request for proposal. This gets to your question. For the peer and performance review vendor. The contract will begin on October 1st, 2019. So the RFP, again, was emailed to you, and I have a copy for the committee on May 17th, 2019. The contract will begin October 1st, 2019. In terms of formula fund priorities, as a reminder, during the February 11, 2019 meeting, the CURE formula research priorities for 2020-2021, this is the formula research priorities, were approved to remain clinical health services and or biomedical research as defined by the Act. Just as a reminder, two non-formula funding categories of clinical and health services research and other research for state fiscal year 2020-21 were combined, which consists of 50% of the funds. We did this in February. I'm going to give some other updates about the peer and performance review vendor, which gets to your question, Doctor. The Commonwealth Department of General Services and the Department of Health is in the process of reviewing the proposals of a peer and performance review vendor. So the RFP went out, the applications came in, and we are reviewing those proposals, and we'll make a decision by October, by when?
Probably in the next week.
So certainly by October 1st. The Health Research Office will keep the committee posted as soon as the chosen vendor has been finalized. So unfortunately, I can't give more details on that. Does that answer your question, Dr. O'Donnell?
It does. Thank you very much, Dr. Levine.
Question. Dwight Davis here. So I take it you cannot disclose the RFPs that have been submitted. Is that correct?
I cannot.
Can you tell us how many? Okay.
We'll tell you when it's. We can because it's still in process. It would violate how RFPs work. So we'll tell you when we're not going to wait till the next meeting. We will send out information when it's done. Right. So that will happen. What's today? The 13th. So within 3 weeks.
Very well.
An update on Act 126 of 2018. As was reported during the February meeting, Act 126, Section 903 was added to the original Tobacco Settlement Act as the Spinal Cord Injury Research Program and has been added as a permanent non-formula research category. The department continues to advise the membership, to establish the membership of the Spinal Cord Research Advisory Committee, and we are looking to schedule an informational meeting as a kickoff before the end of the year. So all that is proceeding. We have identified the funding amount as $1 million, which was the minimum that could be identified under the Act. So it's not going to be more than $1 million. That's under my discretion. The lower amount is $1 million. You asked to be notified of any further changes to Act 2001-77, and as of this date, we are not aware of any proposed legislation or amendments that would impact this Act or this committee.
Question.
Yes.
As I recall, the committee recommended that there be discussion prior to any other proposals that might be put forward.
Right.
In terms of additions.
Yes.
Is that correct?
That is correct. So if there's anything brewing in the legislature, we will keep you informed, and we're pleased to have a discussion.
Before a vote?
Before the legislature votes.
Thank you.
Yes. So as of this date, we are not aware of any proposed legislation by the state Senate or the House of Representatives. If anybody else is, please let us know. But we're not. Okay? The legislature has been looking to streamline state government through the elimination, this is the legislature, through elimination of underutilized or outdated boards and commissions, which in some cases have failed to meet for years or no longer issue reports. For the legislature, the Tobacco Use Prevention and Cessation Authority Committee from Chapter 7, Section 705 has recommended to be abolished. As a reminder, funding changes have occurred since the inception of Act 2001-77. The original funding percentages identified in Chapter 3, Section 306B have been reduced since 2013. So nothing new, though. Appendix B in your packet provides a high-level timeline from the time a funding is allocated to the time The applicant is Award. And Deputy Secretary Meghna Patel and the Health Research Office would be happy to speak with you about that process. So that really does highlight that since the last meeting, we have a new Deputy Secretary of Health Innovation, Meghna Patel, who is joining us today. The previous Deputy Secretary, Lauren Hughes, had left and is doing very well and sends everybody their regards. But Meghna is the new Deputy Secretary, and Penny and the Bureau for Health Research reports to Meghna. Say anything?
Thank you, Dr. Levine. It's my pleasure to be part of this Health Research Office and overseeing this great office here. We have, since I joined, worked very closely with Penny and team here in the Health Research Office and looking into the processes of the applications and how grantees are getting their funds. Certainly the beginning to the end process was my starting point. And as you can see in the Appendix B, we'll be working closely with the Health Research Office and other departments that are involved in sort of improving this process of application. So it's my pleasure to sit in this committee, and also I'm always available here if you have any questions or any concerns.
So thank you. We're thrilled to have Meghna in that position as Deputy Secretary. She previously ran the prescription drug initiated and ran the prescription drug monitoring program, which has been overwhelmingly successful. That is actually still on her portfolio, but at a different level. And Meghna is doing a great job. Penny and the staff are doing a great job, and so we're going to make sure we cross every T and dot every I. We will make sure that if we hear rumblings in the legislature, we will let you know beforehand, before they take votes. And we will keep you up to date in terms of that RFP, the results of that RFP in October. And we'll make sure that we're up to snuff. Before I proceed, are there any comments, questions? Has anybody joined our call? Has Dr. Levine joined our call? Not yet. You'll let us know. Great. Thank you. So the next step is actually the meat of this meeting, where they're going to have presentations for the identification of the non-formula fund priorities for state fiscal year 2020-2021. So our next order of business is to provide committee members with an opportunity to hear from the presentations and ask questions of the presenters. In April, the Department of Health solicited written testimony on the health research priorities via the CURE website. We emailed 8 submissions to the committee and asked members to choose their top 5. The top 5 choices of the committee are present today. Thank you for coming. The committee members requested 2 submitted presentations on cardiometabolic diseases be combined into one. We did also receive 2 additional submissions in August and emailed the committee for their review and interest. The response was positive, and the 2 presenters are included in the schedule. Thank you all for coming. So there are 7 presenters.
Dr. Levine, I have a question about the inclusion of the 2 additional priorities. This is Michelle Masucci. I didn't respond one way or the other to that request because it was my understanding that we had a clear timeline for making the decision about the priorities. Could you explain the process by which the 2 additional concepts came forward? I'm not against them. I just want to say that from the onset, I just didn't understand the process by which that happened.
A committee member emailed them to me, and I asked that I email them to the committee for their consideration of whether they wanted them included. I complied.
Was that done after or before the deadline to actually provide those concepts?
It was after.
So can you explain to me why we decided to change the timeline?
Well, I felt that a committee member wanted to add more, and instead of making the decision not to add them myself, I left that to the committee, so that if the committee wanted to not add them, either because they didn't want them on to be presented, or did not feel that the timeline, that it was, since it was after, it should be included. I felt that the committee should decide that, and that I should not take it upon myself to decide that. And so, there were kind of two questions posed to essentially to the committee. Do you want these two included in terms of their merit? And yes, they were after the timeline, and you can include them or not include them, and the vote was to include them. So I had a choice. I could either say it's too late, no, or I could present it to the committee to decide, and I decided that, I don't know, it would be better to present it to the committee. You can argue that, but that was my decision.
I was just trying to understand. I asked that in light of other deadlines that have been, really kind of dramatically tightened around the rest of the program. And so it's a little, it's hard to figure out why in some cases, around the formula funding, we're being presented really shortened timelines. And on this, we have a lot of flexibility. I just wonder if that same flexibility could be applied more broadly.
Well, I guess it sometimes it could, but sometimes it can't, or the whole process will grind to a halt. So I worry that if we continually extend deadlines, that will not meet the final deadlines for what we have to do, which are already long. So you can certainly argue my decision to let them through. I felt that I'd let the committee decide as opposed to me deciding. Now, if the committee would like to make a motion and then a vote to no longer do that a deadline is a deadline, then I am pleased to offer, people can make that recommendation. Dr. Davis.
Ms. Chair, I'll just make the point that maybe, and we can decide when we want to have this discussion, but my proposed recommendation is that we set timelines and that those timelines are definitive, and that we don't have a situation where a member of the committee can exceed or have us go beyond a set timeline just because of the fact that in this particular case, other researchers who might very well have wanted to provide a proposal did not have that opportunity to do so. So I think just in terms of keeping this process clean, I'm going to propose that at some point in time later, we have a committee discussion.
Okay.
And my proposal is that once the deadlines are set, that we honor those deadlines.
So you don't want to make a motion at this time? You'd like to
I just want to be sure that everyone in the committee, and we have our guests here to present their proposals, that we put this aside and have a conversation later.
So at the next committee meeting?
At the next committee.
Okay. Does that meet everyone's?
Yes, this is Pat Dan. I feel very strongly that once we have a set deadline, we should maintain that deadline. It gives an unfair advantage. Nothing to say that the proposals that were added later weren't wonderful. It's just, I think we need to stick to the guidelines and the deadline, and if we want to do that the next meeting, fine. But I think it cannot be waivable just because somebody decides later they want to enter something.
Okay, thank you, Senator.
This is Dr. O'Donnell. If I could just add one point. I did a quick search of my emails, and I couldn't find any references to that particular circumstance. So I want to agree with Dr. Davis that we have a conversation later so that we don't disrupt our guests. But I do think it's worth maybe building it. And to Senator Vance's point, I certainly appreciate the fact of deadlines. Sometimes, deadlines get extended because, there's a major snowstorm. So I think we need to give ourselves a little bit of flexibility and give our chair, Madam Secretary, a little flexibility depending on the circumstances. So I would suggest that we do have the conversation, but we do delay it to the next meeting.
Thank you. Is there any other comments?
Yes, I want to, this is Michelle again. I appreciate that, and I agree that flexibility matters, but not everybody knew that they could have actually provided additional proposals. And that, of course, has a ripple effect across all of the institutions that apply for these grants. And so it's I think it's important to understand how demoralizing that can be, to see that additional projects come up because somebody asked and somebody else didn't think to ask. And so then therefore they're not being considered at all. So I think that's really an important aspect of this that we shouldn't lose track of just because we're talking about deadlines. The other comment I want to make is simply that on the deadlines on the non-formula proposals, it's not the issue of the deadlines, it's the issue that there's a review process that goes on that in the past has been somewhat iterative, and now my understanding is it's not, and yet there's not a lot of transparency on what comprises the decision as to whether or not a project does or doesn't get selected. And so if there's any clarification that can be brought forward on that, we have attempted, I believe, no fewer than 5 times to try to get clarification on a few of those issues, and no one's returning our calls.
Dr. Masucci, this is Meghna Patel again. I'm the Deputy Secretary here. I believe you're asking about a process of how topics come forth by the committee and how, when the proposals come in,
No, I'm sorry. I'm talking about the non-formula program in which the universities that meet a certain threshold of PHS funding at the federal level receive an amount of formula dollars, which they then map onto specific projects. Those projects are submitted to the state for review. In the past, there has been a somewhat iterative process on that review. My understanding is the iterative process is no longer going to be done, and that's of great concern, I think, for all of the formula recipients. I wonder if there is any, if there's going to be any kind of flexibility on that at all, because it's making it very difficult to actually plan internally.
So my suggestion is if you can email me personally that issue, I will discuss it with our team, and then we can set up a phone call, and any of the committee members that want to be on the call, we can do it. But I think I need a little time to sort out with my team that answer.
The problem, Dr. Levine, and I really appreciate that, is that the grants are actually due to the state on September 24th, so there's very little time left to sort out any issues around the process. And we haven't been able to get clarification on basic issues. And so now we're left, really trying to figure out how to allocate the dollars without answers to basic questions, and an instruction that if we don't get it right, we won't get our formula dollars.
Well, email me today, and I'll meet with my team tomorrow.
Is there any chance that that deadline would be extended to leave time to do this clarification process? I'm hearing from our team that would be really difficult. Well, then how do you expect the universities to work this? Because we haven't been able to get answers to questions for 2 weeks now.
Yes.
Dr. Masucci, how about we take this as a priority on our side at Department of Health? I'll be happy to call you tomorrow, and as we have the answer established, we can walk you through the whole process.
I'm fine with that, but that's another day on what's only about 10 business days left. Is there any chance of extending that deadline?
Well, I don't think so, but I'll tell you what, Meghna will call you this afternoon.
Are any of the other institutions facing the same challenge?
This is Dr. O'Donnell. I really only became aware of this in this conversation because I've been indisposed for a number of weeks. So I appreciate the timeline and the circumstance, and since I've not had any opportunity to talk with colleagues at my own university, I don't know what their circumstances are. So I can't speak to that, but I do appreciate what Dr. Masucci is saying, and I do appreciate the fact that we want to always even-handed, which I think is the point that Senator Vance was trying to make. So I think any resolution that can be quickly gotten under this set of circumstances, given the concerns that Dr. Masucci is raising, would be welcome. And I would just like to be in the loop for outcomes of conversations and/or participating conversations if possible.
Dr. Davis.
I would just recommend, in terms of the time frame and in terms of us being able to move forward, maybe involve all of us in the subsequent conversation and the situation raised, and we can try to address that within a short period of time.
Sure. So, Dr. Masucci, Meghna, would you prefer to be called today or tomorrow?
I think sooner would be better. So maybe after this call, if everybody wants to take a moment to have a break early this afternoon, would work. And to be clear, we're not concerned about the deadline. We're concerned about the inflexibility on the back end of the deadline, which is putting much more pressure on the system to meet the deadline than would otherwise be the case. That's the actual issue.
Thank you. So does everybody want to be on that phone call, or should that phone call be with Dr. Masucci and then we'll send out an email?
Meet with Dr. Masucci. My recommendation is please meet one-on-one and then send us, if you will, the situation and what might be a resolution.
Very good. So Meghna will talk. I have some other responsibilities, but Meghna will talk with Dr. Masucci today, and we will send out a clarification email tomorrow.
Thank you.
Thank you.
I really appreciate it.
Thank you.
I agree with that summation, and thank you.
Sure.
Thank you, Dr. Levine. That was very helpful.
Thank you. Okay. So I think we're going to move on to, so the next order of business is to provide committee members with an opportunity to hear the presentations. There are 7 presenters. We have allotted 10 minutes per presentation. And we'll let you know when it's 9 minutes. There'll be time some questions. We're gonna go from one to one, but there'll be questions at the end of the session. So if the presenters would remain, I guess if you can't remain, then let us know and we'll get questions answered right away. But if you can remain, that would be best. We ready to proceed? Very good. So at this point, I would like to invite Dr. Chris Etherton from the Penn State University to present, and please, anybody presenting with you to introduce themselves.
Thank you very much for the opportunity to be here today. Can everybody hear me?
Well, yeah, so how do you want to do that?
Okay, so they come over here? Yeah. Okay. Thank you. So, okay.
Yeah, I think that maybe it would be best, why don't you sit over there?
Sit over here?
Right at that open seat.
Okay.
We'll move that, and then you have a clicker?
My God. You can work. It works. It might work.
Oh, it does? Should I stand? Okay. But then will people hear? Okay, maybe they'll hear me.
Let's see if they'll hear me with a mic.
All right.
Okay, can everybody hear me on the phone?
Can you hear her on the phone?
Yes.
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 Please proceed.
Okay, thank you. And thanks so much for the opportunity to be here today to talk about cardiometabolic diseases. And in particular, I'm going to talk about benefits of good nutrition and both the prevention and management of cardiometabolic disease using team-based science. First, let me acknowledge my co-authors on this, Dr. Kathy Ross, who's the department head in nutritional sciences at Penn State, and my colleague, Dr. Christina Peterson, who's an assistant nutrition research professor. So the next slide shows major risk factors for cardiometabolic diseases. Now, at the center of this slide, we see major cardiometabolic diseases, including cardiovascular disease, stroke, diabetes, as well as metabolic syndrome, not shown on the center of the slide. But what's really important is that there are many risk factors for cardiometabolic disease, and many are modifiable. Many have a nutrition link. So let's take a look at these. Insulin resistance, overweight, obesity, abnormal lipid lipoproteins, poor diet quality, age, race, sex, family history, inflammation, hypercoagulation, hypertension, smoking, and physical inactivity. So it's really a complex condition. And so the key thing I wanted to point out is nutrition can affect a lot of these risk factors, including overweight and obesity, which affects insulin resistance, and then lipids and lipoproteins, inflammation, and hypertension. So there are many modifiable risk factors for cardiometabolic diseases. Next slide, please. As you see on this slide, the leading cause of death in the United States in 2016 and 2017 was heart disease. Well, cancer is a close second, but interestingly with heart disease, we don't see any changes between 2016 and 2017, and actually very recent data are showing an uptick. So it's causing a huge financial burden in the United States, globally, as well as Pennsylvania. The next slide shows leading risk factors for death in the United States, and this is from the Global Burden of Diseases study, published very, very frequently. We see that dietary risks are a leading cause in the United States. And what I think is important here is that if you look at the other risk factors, diet affects practically all of us. Now, not smoking, but high blood pressure, high body mass index, high blood sugar, and high total cholesterol levels. So there's a key role for diet and nutrition in impacting the prevalence of cardiometabolic diseases. In the next slide, we see leading risk factors that contribute to death and disability in Pennsylvania in 2007 and 2017. And look at the top three in 2007. Tobacco, dietary risk, number 2, and high body mass index, number 3. Well, the same top three are listed in 2017, except obesity now is number 1. Dietary risk is number 3. But as you know, obesity has a real important nutrition link. The next slide shows just how terrible the American diet is. And here's a slide from the 2015-2020 Dietary Guidelines for Americans. And what we see on the right-hand side is evidence of the percent of the population that is above the recommendation. And on the left-hand side, evidence percent of the population below the recommendation. And what we see here clearly is that Americans are not consuming enough vegetables, fruits, total grains, dairy products, lean protein foods, and liquid vegetable oils, and we're consuming way too much added sugars, saturated fat, and sodium. Next slide, please. So our diet is really terrible. Boy, we need to do a lot with it, but this slide shows that just small changes can have a big impact. Several studies show that just a 1 to 2 point increase in diet quality can have a significant impact on cardiovascular diseases. And so this is on a 14-point scale. And what is 1 to 2 points? It's eating 1 more piece of fruit per day. So
excuse me, I don't mean to interrupt, but you're getting more and more quiet. You need to speak up a little bit, please.
Good. Okay. I'll talk more into the mic. Okay, so the next slide shows increasing prevalence of adult diabetes in Pennsylvania. And this is diagnosed diabetes. And what we see is just an alarming trend from 2004 to 2016. And interestingly, we see, a higher prevalence in certain pockets of Pennsylvania as well. We really need a lot of help. The next slide shows that Pennsylvania really is in a prime position to conduct impactful research on cardiometabolic diseases. And I've just listed some of the universities where there's a lot of work going on already, but just even in a lot of the smaller medical centers and universities, there's research that is being conducted. But you can see at the University of Pittsburgh, Penn State, University Park campus, Hershey, and then, of course, in Philadelphia, there are a number of universities already conducting a lot of cardiovascular research. Geisinger, and then even Marietta is conducting research in the area of the microbiome. So the next slide shows that cardiovascular disease is a chronic disease. And, its roots begin in childhood, but yet it's not manifested until later in life. And, boy, what we really need to do is prevent, the full-blown heart attacks and strokes that occur mid-life by early detection and diagnosis, because that's when it's all starting. Next slide, please. In medicine now, we're in an era of talking about precision medicine, personalized medicine, and figuring out what the best treatment is for individuals on the basis of clinical features, patient individual preferences. And that's where I think we need to go, is to delve into identifying factors that identify what the best treatment would be for individuals for the biggest impact. And the next slide basically shows that we really do need cutting-edge approaches at the intersection of biological, metabolic, and environmental risks to tackle this 800-pound gorilla that we're dealing with. We need, to advance basic science and social science as well. And we even need to do more in education and dissemination to get the word out about prevention and best treatment practices for cardiometabolic diseases. So the next slide basically shows that with CURE funding, Pennsylvania scientists can provide new knowledge on both healthcare providers and the public need to, diagnose and treat, prevent cardiometabolic diseases right from the get-go. And I think Pennsylvania is uniquely positioned to disseminate knowledge. So SNAP-Ed is a very, very big program in Pennsylvania. We have ag extension efforts, and then there are many people in Pennsylvania who serve on clinical practice-based guidelines. We have 3 CTSI, Clinical Translation Science Institute centers in Pennsylvania. There are only 61 nationwide funded centers, and Pennsylvania has 3. One at Penn State, one at UPitt, and one at UPenn. So basically the next slide shows that because of the complexity of cardiometabolic diseases, we really need team-based science to help understand the multifaceted, synergistic, and etiology of cardiometabolic diseases. So there are a lot of different types of studies, next slide please, that we would envision could fit with a priority on cardiometabolic diseases. So here are 3: impact of diet and nutrition on early onset diabetes in Pennsylvania children and young adults, early detection by identifying biomarkers of cardiometabolic diseases in overweight, obese children and adults, and what the effects of nutrition is, and then also understanding basic science, mechanistic underpinnings of cardiometabolic diseases, and the role that nutrition plays. So, okay, in summary, perfect time, cardiometabolic diseases make a very significant contribution to the health burden in Pennsylvania, the United States, and globally as well. And so that we need new discoveries and to deal with this terrible problem. And so that engaging scientists with complementary expertise to conduct comprehensive, cutting-edge research into development and progression of cardiometabolic diseases is really what's needed. And so that we think that with advances in nutrition and cardiometabolic research, it can have far-reaching population efforts, and it could really help the population of Pennsylvania and beyond Pennsylvania as well, and really have a very big impact on direct and indirect costs associated with the burden of this disease. Finally, thank you very much for your attention.
Thank you very much for that presentation. We could probably take a minute for any questions. Dr. Davis.
So it appears to me as if there are multiple components. Can you briefly state it? It seems to me as if there has to be some, if you will, centralized coordination of both the science as well as the educational component. Is your proposal that the funding or the dollars go to some centralized location and you have outside folks that work on the various components in terms of science and education? I guess what I'm asking is, how are you going to spend the money?
Well, I think that that's a very good question, and we hadn't gotten that far yet in deciding what the best way would be, but I think that that would be a very good model, some sort of centralized model that makes sure that a lot of bases are covered. And so maybe, a core pot of money to a centralized location, but with opportunities for, other groups to contribute and play a role.
This is Michelle on the phone. This is just a point of clarification for the consideration of the committee. I apologize for interrupting at this point. Are we deciding on these specific projects or just the concept being introduced to which everyone would apply as an RFP?
Just the concepts to which there would be the usual RFP. So the
and
concept,
are these presentations the actual description of what would go into the RFP or just the sort of topical focus that would go in?
Topical focus.
So from this slide presentation, what we would be deciding on is, would we extract from this and align with the priorities, the RFP that would go out? I'm just trying to understand the process by which we're going to go from these very detailed presentations into the broad announcement.
So this is what the committee asked for in February, was to have presentations as opposed to white papers. And so that's how we got these proposals, and we chose initially 5 out of 7 topics, and these are researchers presenting a general topic. So cardiometabolic research, nutrition as a topic, and then there'll be the usual RFP process. But this is instead of the white papers.
I know. Well, this is my question, though, is so how do we go from the PowerPoint to the actual RFP? Is the PowerPoint going to be the RFP?
No.
So that's what I'm trying to understand, because that'll help me determine how I'm going to select what I think we move forward with.
Penny?
After the presentations are finished, there will be that same discussion.
So we will discuss after the presentations are done, we take a break. We're going to come back, the presenters will leave, and then we have a committee discussion in which we can either choose the topic or decide that you need more time to think about it, and then we'll do it by email soon. So we can either have a discussion to choose the topic after the presentations, or if people need more time, then we'll do an email poll.
Thank you. I appreciate the clarification. I'm sorry if I missed that detail in the discussion earlier, but I just wanted to be sure what I was listening for in reviewing these. I very much appreciate the clarification.
Sure.
Thank you. And thank you for the presentation.
Sure. Thank you. Great. Let's move on. Dr. Buttenheim from the University of Pennsylvania. Did I pronounce that correctly?
You did. Thank you.
Wow. Amazing.
Thank you very much, Secretary Levine and the committee. I'm really delighted to be here to share a topic I'm very passionate about and I think could really benefit from investments of non-formula funds from the CURE program. I want to talk about innovations to increase vaccine coverage and reduce the vaccine-preventable disease burden in the state of Pennsylvania. And just by
little louder, please.
Sure, I'll get right up next to the mic. How's that? Just by way of sharing where we are in terms of preventable disease burden in the state, I just wanted to share 3 recent past couple of months health alerts that Secretary Levine had to send out to the state around 3 vaccine preventable diseases, mumps and influenza, both in March and more recently in July, measles. I'm sure I don't have to convince this audience of the scope of the burden of these diseases. They are not gone. We think of some of these diseases as gone from our country and from our state, and they are not. And obviously, big cost to the healthcare system, big burdens to the population, and considerable cost to the state to track and control these diseases. And of course, the reason why we have a vaccine preventable disease burden is that our vaccine coverage is not optimal. I'm going to show you an example for the influenza vaccine. I could repeat it for almost every vaccine in both the child series and the adult recommendations. Here is influenza vaccine, comparing our 2020 Healthy People goal of 80% for adult flu vaccine coverage. And in 2016 in the state, we were at 35%, so well below optimal level. Big gap there. And of course, within that coverage in the state, we have considerable disparities by socioeconomic status, by rurality, and by a bunch of other measures. It's interesting, they vary quite a bit by which vaccine. But for flu vaccine, if we just look at education, our college-educated population has about a 42% coverage among adults. Among our less than high school educated Pennsylvanians, at almost half that rate. So, and I could repeat that for almost every vaccine in the series, because deliberate vaccine under vaccination by parents is actually an epidemic of privilege. These disparities can actually look quite surprising as well, not always in the expected direction. We were asked to talk about both what to include in a research agenda funded by non-formula funds, as well as what not to include. So I thought I'd just kick off with what not to include to get that off the table. I see 4 areas where I think non-formula funds are probably not the best fit. The first is around new vaccine development. That gets funded through other mechanisms, I think, quite well. The lead times are very long, and probably not something where the state is going to see a return on those research investments very soon. The next 2 are vaccine efficacy and vaccine safety. I would say for the vaccines on our schedule, that's settled science. Don't want to reopen that bucket at all. And for new vaccines in development, that's actually part of the vaccine development process. And the 4th is the content of our school entry mandates. Each state, as you all probably know, decides which vaccines and which doses are required for school entry. I think with the exception of HPV, which some states are considering, that's probably not a particularly fruitful area. So the rest we don't include in the RFP list. But let me touch on 3 areas where I think research is needed, where Pennsylvania is well positioned to do a lot of that research, and where, again, I think the state would see returns quite soon. The first is the design and then dissemination of effective ways to promote vaccine uptake. This is both in clinical care, this is giving clinicians guidelines about this, and at a public health population level. The questions there are, what messages are most effective? I sort of thought we knew a lot about this 10 years ago when I started working on this topic, and I can tell you, talking with clinicians, that they really want evidence-based guidelines on how to support parents in making these decisions and how to promote vaccine coverage for adults. There's a lot of heterogeneity, again, in who can pay attention to and who can take advantage of vaccine promotion messages. So learning about that variation in response to messages is important, and then how to target those messages. Again, clinicians, very busy, might have a couple of minutes to talk to a parent or to an adult about vaccines. We have limited attention span in the public health promotion space. Really need to learn how to target and tailor those promotion messages. And I wanted to highlight also some methods, some methodologies that we might bake into the RFP that I think could be productive as well. I have a bias towards my own methodological orientation towards behavioral economics, around sort of the science of judgment and decision making, and taking advantage of what's known about how people pay attention to information, process that information, and make decisions to help in that message development. Data science could be extraordinarily helpful here if we can get a large data set that has patterns of vaccine acceptance. We can start to look for typology, phenotypes, sort of behavioral phenotypes of who's vaccinating where and why and for what diseases. And finally, my hands are shaking. The third. There we go. Obviously, the science of communication, right? So once we have these evidence-based messages, how we frame them and package them for both clinical care and public health promotion. So the second broad topic is innovations in vaccine service delivery. Most of us get our vaccines in primary care, sometimes in inpatient care, and a smattering of other locations. We might go to a worksite-based flu vaccine clinic. Very few people take advantage of retail pharmacies as a site of vaccination. That's kind of it. We think there's a lot of opportunity to expand and innovate around how we do vaccine delivery. One exciting example I'll tell you about at the University of Pennsylvania, we have a partnership between the nursing school and the School of Veterinary Medicine, thinking about whether we can train veterinarians as nurses to deliver human vaccines. We have a rural population in Pennsylvania that may see their vet more often than they see a human health provider. This is an exciting opportunity. Second quick example, we do a lot of work at Penn on libraries as sites of public health and public health promotion. We're training librarians in naloxone use for opioid overdose reversal. I think there are opportunities to make libraries a site of vaccination also. So the questions here are, where might we deliver vaccines that we don't currently do? How can we sort of meet people where they are? Who are the providers that can deliver those vaccines, and how do we get them to those places? And of course, this opens Pandora's box after Pandora's box on reimbursement issues and licensing issues. And I think there's actually important research to be done around those topics as well. Methods that could be helpful here. I'm a big advocate of rapid cycle prototyping and other innovation and design methods. We tend, as researchers, to set up these big, long, complicated trials and let them run for a year and sort of maybe learn at the end that something worked or something didn't. I think much more rapid, iterative, small-scale pilots could be really effective. If it's possible to bake that into the RFA, I certainly would, and happy to talk more about that. Because we're talking about sort of pushing the boundaries a bit on reimbursement and licensing issues, I think waivers and demonstration projects will be important here. And finally, implementation science. As our previous presenter mentioned, there's a lot about the rigorous, strategic, systematic approach to implementing evidence-based practices. For example, if we're going to do this vet-nurse thing, thinking about how that gets rolled out and how that gets scaled. The third topic is one that I spend a lot of my time working on, which is state laws governing school entry mandates. If you've paid any attention to what's going on in California, they have been repeatedly changing and in their case making more difficult the process by which parents can get an exemption from school entry mandates. They just passed their third change to those sets of laws in 4 years this week. Pennsylvania often has been considering and reconsidering, also tightening their exemption laws, removing religious exemptions. A lot of questions about how to do this from an evidence-based standpoint and not just sort of a politically reactive standpoint, and then the devil's in the details on this, how this gets implemented. You may know in 2017, Pennsylvania changed the law for the duration of the conditional admission grace period, provisional admission, as it's called in Pennsylvania, which went from 8 months. So a child had 8 months to clear a provisional admission during the school year. That was reduced to 5 days in 2017. That created a lot of sort of reverberations through both health service delivery and in schools at the start of the school year to accommodate that very rapid shift. How school nurses get involved, how education and health departments have to collaborate, I think is a very fruitful area of research because the implementation of these new vaccine mandate exemption laws is really key. Another issue that came up in Philadelphia, the school entry mandates for vaccines have teeth because if parents don't comply, the child can be excluded from school. School nurses in Pennsylvania, following the new provision, were trying to exclude children who had not met the provisional admission requirements. The Department of Education, the Department of Health finally said no exclusion. So you can argue that whether that makes sense or not, but if exclusions aren't enforced, school entry mandates basically can't be enforced as well. So no state has figured this out, and Pennsylvania is very well positioned to do that.
And Dr. Moon, on your ballot, 10 minutes.
All right, so 3 methods there I think are helpful, and a summary of what to include, and happy to entertain any questions.
Thank you.
Are there any questions? Dr. Davis or anyone on the phone?
I have no questions. It was a nice presentation. I appreciate it.
No question.
Well, thank you very much.
You're very welcome. Thank you for the opportunity.
Dr. Huang.
you guys. Thank you for inviting me to present. For the previous two presenters, I like everything there. I love the team science approach. I think the population.
Louder, please.
Okay, now it's real my presentation.
Move the mic.
Yes, here. The small talk in the lobby, and the one present asked, what is selling? I'm actually not sure what's selling. I'm selling a concept. And science and technology bring many wealth and health, and including longevity to the world and Pennsylvania. And then, although there's some recent downturn, there is a decrease in life expectancy, particularly in rural American place. And in addition, the majority of gained longevity from our discovery is actually finding poor health. Indeed, the top 4 of the cause of death, top 5 cause of death in Pennsylvania is chronic disease. The chronic disease is different from the infectious disease or acute injuries because you know what caused it. The chronic disease is more insidious and probably relate to the interaction between our genetic makeup and the environmental, the complex etiology. I think it's really imperative to starting address this age-related chronic disease by capitalizing the science and technology provide to us. Oh, wait, why am I went backwards. So I'm bad driver here. How do you drive? You convince me.
But you still have to stay near the...
I say how you drive. Okay, so next slide, please. Like the world, Pennsylvania also grew older. We have 30 million people who are older than 65 years old. And we are home of 300K of older folks than 85 years old. We're aging 20 times more than any other population. And in Pennsylvania, actually, the older folks, they care about health. I showed a picture of my group I went to call one of the aging expos. You can see there's one gentleman who has oxygen tank, that's the respiratory disease. And there's somebody hunched over to reading what we have to say. They want to be healthier. Next slide. I just always feel when I want to propose some older disease, when I'm growing older, it must be self-serving. I want to address that. For example, so I'm a Parkinson's doctor. A chronic disease doesn't affect just one person, it affects the whole family. So with the family permission, I'm going to tell you this little story. So Joseph was born after Dad was diagnosed with Parkinson's disease at age 35. At age 19, he's the primary caregiver to his father, who wheelchair bound. And he's depressed, anxious, feeling tremulous, maybe from coffee, but he's worried. He came to my clinic at age of 19, only had one question for me. Dr. Huang, am I going to have Parkinson's disease? At that moment, I don't know what to say to him, okay? I don't know, could genetically make up, the environment can change a thing, but I cannot tell he will not have Parkinson's, will have Parkinson's. Only one thing I can say. Also, if you ever have Parkinson's disease, I promise you, your future will be much brighter than your father's. Okay, fast forward 5 years past. His dad, at the age of 67, fighting his life with a past and trick and everything, contribute everything he can for our research mission, for us to do that promise. At the age of 24, and then 2 months ago, Joseph engaged happily. He trusts us at this moment, a promise that made me 5 years ago. His future will be brighter when he and his wife will venture the new world. This may have a profound impact on me. So whatever disease we're treating, just remember that. That could be Parkinson's, COPD, dementia, asthma, you name it, heart disease, survival of cancers. I think that can impact everybody. Next slide, please. So of course, I give you example of Parkinson's because I know. So ask the Joseph question, what caused Parkinson's disease? One of the reliable evidence of Parkinson's environmental cause is one of the pesticide called paraquat. The maximum for anybody know farming is actually using 120 countries, including Pennsylvania. This is geocoding. I don't have a technology to follow that up, but Pennsylvania is very much recipient. Oh, I gave you the wrong slide deck. I think you didn't replace it. Okay, let's keep going. Okay, go to the next one. Go next. Okay, that's it. Okay, sorry, I cannot update, sorry. So I try to be shorter to 10 minutes. So that's a paragraph is actually very relevant. Farming is one of the big economic forces for our rural Pennsylvania. And actually throughout the paragraph, one called Parkinson's in animal model and the human epidemiology also widely used in this. Actually, remember this slide is 2012. We want to update 2016 is doubled in the 4 years because of the economic concerns. Next. Also, as a place with many manufacturing works, welding actually is one of the with no link to manganese exposure. 200 years ago, we know links to Parkinson's disease, and low exposure, we also know what health impact for us. So next slide. I don't know what my time is.
You're at 7 minutes.
Oh, okay.
6 minutes.
My time's good. Good. So this is not the concept. I only give you 2 examples for the disease I know of. Probably involved the environmental and our genetic interactions. And I actually propose, here's a propose. You take a village. Oh, no, it takes beyond a village. It takes multiple villages. And to deliver that promise I made for that 19 years old, for our next generation, the healthy aging. And I'm thinking this is what I envision the research direction to conquer that problem. From community engagement to understand etiology, exposures, what have it, and also to understanding early detection. Can we intercept them? What we can do about it? That's exactly Joseph's question. And then to disease happening, how we can optimize quality of life, what we can do better. Last, most importantly, as a urologist, I didn't know that, you guys all know, is we had to hold us accountable for deadlines. Before I met that little boy, 19 years old, I don't know how many paper grants I've written before. I use the word in the future. In the future is a day never comes. Future never has meaningful. Future will be where I get papers. However, that day when I met the little boy, the future had a face. Future had a timeline. He's 24 years old. 5 years later, I didn't know we can deliver that future for him. Thank you.
Thank you very much, Doctor. Are there any questions? Thank you very much. All right, we're going to be moving on to Dr. Finkel.
Can you hear me?
Yes, we can hear you.
Fantastic. I apologize. A commitment here in Pittsburgh didn't allow me to be there in person, but I appreciate this opportunity. Can I, if I take over as presenter, does that work?
I don't know. I think you just have to say next slide, sir.
Okay. Are you guys going to bring up the presentation?
Yes.
He's working on it.
Okay. I'll sing background music in the meantime.
That would be lovely, sir. You're a baritone or a tenor?
I don't know. What would you like? Like raindrops keep falling on my head or something like that. That's always in the elevator. Oh, fantastic. Okay.
All right, I think we're there.
Okay, thank you.
Let's say next slide when you're ready.
Okay, thank you so much. So I appreciate this opportunity. I'd like to propose for your consideration this notion of geroscience, which is this idea that we can begin to address the issues of chronic disease by really targeting uncovering and targeting the basic biology of how and why we age. And I think we all appreciate that age is intimately linked to a variety of diseases and conditions of citizens of the state. And I was actually trained as a cardiologist, so if you go to the next slide, please. I think just to give you a sense of the magnitude of the effect of age, next, that I think epidemiological evidence has delineated a variety of risk factors for cardiovascular disease. So for instance, if your cholesterol is elevated, you have about a twofold risk of a cardiovascular event over 10 years. Next. Similarly, blood pressure raises that risk threefold. Next. Diabetes, again, around twofold. And next. Smoking, again, around twofold. In contrast, if you're a man aged 70 to 80, as shown next, your risk goes up about sevenfold. And that's the relative magnitude of age versus these other of known risk factors. So next. I shouldn't have animated this slide. We've made incredible progress reducing the burden of cardiovascular disease by targeting things like cholesterol and blood pressure, these so-called modifiable risk factors. And by doing so, as I said, the deaths from cardiovascular disease has really dropped dramatically in the U.S. However, as you can see, we've left on the table the single greatest risk factor for this disease. Next. And the question is, if age itself was modifiable, we could begin, even a small change in sort of biological aging could have a tremendous effect on this disease. And next. And it's just not this disease, because every disease that we worry about for ourselves, if we take care of patients, for our family member, every disease, cardiovascular disease, neurodegenerative disease, cancers, they all have the same sort of incidence in terms of age, and that there's a relatively low incidence when we're young and an exponential rise as we get older. And really the geroscience hypothesis that I'd like you to consider is that while NIH and medical schools and drug companies have been focusing on developing therapies for these diseases that affect us, by targeting the sort of y-axis here, by getting specific therapies for each of these conditions, we want to propose a new approach, a very orthogonal approach, that is to target the x-axis and begin to understand how and why we age, how fast we go along that x-axis, in an attempt to develop therapies that really target all of these diseases simultaneously. And that's sort of the hypothesis that a lot of laboratories in the state and other places are pursuing, and which I think is an intriguing thing for your committee to consider. I think the good news, as shown on the next slide, is that the basic biology of aging is being teased apart. And this is a sort of well-established cartoon in the field where a number of sort of intrinsic drivers of human aging have been delineated, and their contribution to aging, as I said, are being worked on in a variety of laboratories across the country. And this understanding of how and why we age is giving rise to new therapies and new approaches to diseases. And I just wanted to take a few examples of that to give you, I think, the power and flavor of this approach. So one of these conditions, one of these hallmarks of ages or drivers of ages, as you can see, is the concept of cellular senescence. And so the next slide, please. So cellular senescence is this idea that if a cell undergoes damage, sort of chronic constitutive damage, it may not be enough to induce cell death through apoptosis, but it produces this alternative state where the cell no longer is capable of dividing, but now exists in this sort of chronic sort of zombie senescent state. But in that state, it secretes a variety of sort of what, for lack of better terms, are evil humors, a variety of inflammatory cytokines and damaging things that affect both the neighboring cells and the body as a whole. And that's given rise for people to begin to develop what are called senolytic therapies. And as shown on the next slide, this is a recent trial from a group at the Mayo Clinic, which is sort of pioneering this approach, where they've combined two agents together, both of which are not senolytic individually, but together appear to sort of specifically kill senescent cells. And they're treating, in this case, a group of patients with idiopathic pulmonary fibrosis, not aging itself, but a disease, in this case, in the inherited form that's caused from telomere deficiency, and which causes an accumulation of senescent cells in the lung. And so they're just beginning this work, but at least these types of trials are ongoing. And I think provide a glimpse of what the future might bring. Next slide, please. We here at Pittsburgh are taking a slightly different approach, and we're just about to begin a trial here in the next few months, targeting this inflammatory cytokine IL-6. Interleukin-6 is perhaps the best indicator in the elderly of who's going to die and who isn't, who's going to undergo frailty, a variety of morbidity and mortality. It's perhaps the single most best indicator of poor aging versus healthy aging. And so we're going to take a group of about, as shown on the next slide, we're going to use, in this case, sponsored by a philanthropic support, we're going to use an antibody against IL-6 to target patients who are elderly but in a sort of pre-frail condition who have high IL-6 levels, and ask whether reducing IL-6 over the course of the year improves their ability to walk on a treadmill, improves their muscle strength, improves their cognitive ability, improves their ability to respond to things like flu vaccinations, etc. So again, another indication, I think, of this pushing this geroscience hypothesis into the clinic, and have been to really try to bend the trajectory of aging and the incidence of chronic diseases. Next slide. So this is, again, just two examples of many other approaches that are beginning to emerge in the clinic here in the state and around the country and around the world, that really, again, are promoting this idea that if we understand why and how we age, we can begin to develop this whole orthogonal set of therapeutics that will target aging biology and that will in turn affect our propensity for a variety of diseases. Next slide. This is, I think, an incredible strength of the science in this state. My particular lab is interested in mitochondrial function and how it might affect aging. And every year, scientists in Pennsylvania who are interested in mitochondrial function, you get together, we alternate where we're going to be. And then in 2 weeks, we're going to be, this year, in the Philadelphia area. We go between Pittsburgh, Hershey, and the Philadelphia area. And again, a lot of colleagues from all over the state will be gathered there. And again, the focus will be, in many parts, this idea of geroscience and how it might be targeted for therapeutic benefit. Next slide. So just in summary, next, what I'd like to propose is that this RFA not be a specific disease like cancer or Alzheimer's disease, next, but really how aging tissues and organs might provide the soil that allows chronic diseases to emerge. So next, examples could include, next, for instance, how, for scientists who are interested in the immune system, how the aging immune systems allows the development of chronic diseases to emerge, diseases like cancer and Alzheimer's. Next, whether or not we can determine beyond, I showed you IL-6, but I think there are better ways to determine who's going to be a healthy ager and who's not going to be a healthy ager. Next. Can we develop better anti-aging drugs? I've shown a few of them, but I think there are much more to be done here. And I should say that there's a number of small biotech companies and biopharmaceutical companies that are trying to pursue this target, both in the state and outside the state. Next. And the sort of general idea is, can we intervene on the central regulators of aging to prevent age-related disease? So next slide. In summary, I get this. What I'd like to propose is that we can target the underlying biology of aging to treat diseases. Our goal is not to make people live longer, but actually to make them live healthier lives free of disease. We think that this is really at an incredible inflection point in terms of the science that has emerged over the last 20 years, and that we can really begin to develop new approaches that I said, again, that target that x-axis versus the y-axis of disease, that really fundamentally change how we treat chronic diseases. I think there's a lot of competition in this area. Other states, other universities are obviously pursuing. I think Pennsylvania has a great network of talent, and I think we can, with this catalyst, we can certainly lead the way. So thank you very much.
Thank you so much, Dr.
Let me just, sorry, one more slide. I'm sorry, I have to end with demographics. Go back one slide. I should say that from what I could see, Pennsylvania is actually the second oldest state in the country. It's the second highest percentage of people over the age of 65. That's not, the planet is getting older. This is an incredible graph from the UN looking at people on the planet who are over the age of 65, shown in brown, versus under the age of 5, shown in black. And since time immemorial, the number of people under the age of 5 on the planet has greatly exceeded those over the age of 65. And about 6 months ago, according to the UN, for the first time in human history, those two curves crossed. And now on this planet, there are more people over the age of 65 than there are under the age of 5. And as you can see, it's not going to get any better. So that by the year 2050, those curves actually will be the mirror image of what they were just 100 years earlier. And the number of people on the planet, the number of people in Pennsylvania, the number of people in the U.S. over age 65 will greatly exceed the young underage population. So understanding how and why we age, developing new therapies that target the rate of aging biology, and using those therapies to treat chronic diseases, I think is a very attractive way that the Cure funds can be spent. So thank you very much.
Thank you, Dr. Finkel. Are there any questions?
No, it was a great presentation. Thank you.
Thank you.
Great, very good. We're going to move on. Dr. Jurajan, did I pronounce that correct?
Yes.
Oh my goodness.
Thank you very much. I think I'm going to talk about a very important topic, and this is going to be a topic about our future, that is our children. So if we take care of our children today, we are actually preparing them to be better citizens tomorrow. And a major aspect that has been affecting children today is autism spectrum disorders. And autism spectrum disorders have been identified where diagnosis can be made with the technology today as early as 2 or 3 years old. And they have a highly variable set of symptoms and varying in severity. And as the name states, it's a spectrum of multiple different psychiatric and developmental disorders all put together. And this is a very complex disease with a really high sex bias. There are more males than females affected with autism. And while behavioral therapies are really effective, but they have to be really customized or personalized. And also, over the long term, I see many people talking about chronic disease and diseases or disorders in the aged population. This is going to really impact future because this is also leading to a decreased quality of life and also shortened lifespan. So what are the biological aspects of autism? What do we know today? So it's a complex disease. There are multiple different factors. It involves multiple domains of science, multiple domains of social science, multiple domains of people in multiple different sectors, in industry, for example. And the biological causes are, one is the genetic factors contribute to autism. We've identified more than 200 genes to be contributing to autism. Some of these are really syndromic. And I'm sure if I ask each one of you, do you know of anybody who has a child with autism, you're going to say yes. And this is so prevalent. And there are also environmental factors. For example, we are an aging population. We are delaying the age at which we have children. So advanced paternal age, father's age determinants, actually has a contributory factor for the cause of autism. And there are maternal conditions such as infection, maternal infection, and also the diet during pregnancy is very important that contributes to autism. Nutritional deficiency has been associated with autism. So what is the global impact of autism? Why do we really care? Well, about 2% of the population are affected with autism, and especially in the U.S. And I think this is still underdiagnosed because this is diagnosed only by through real formal means in hospitals, in child services. But in the longer term, there's a lifelong care that is often required for individuals who have autism. You need medical and psychiatric treatment, special educational services are involved. The individuals who end up growing up, they need assisted living care, and many of these end up having unemployment. In fact, more than 50% of the individuals with autism end up being unemployed. and loss of productivity for patients as well as caregivers. If you see all these children who have autism, if you look at their parents, they are more suffering. They're actually having a lot of issues in dealing with their own lives, and there are a lot of loss of productivity. And in the longer term, there's decreased lifespan and increased risk of mortality due to all these comorbid features, and this can lead to multiple different aspects in terms of morbidity, such as circulatory or respiratory failures, and also suicide that would lead to death in these individuals. And also the total estimated cost per person is somewhere between $1.4 to $2.4 million. So it presents a really widespread social and economic burden. And really look at the societal impact. What's happening here in Pennsylvania? So if you look at just the adults who are receiving services with autism, it's actually, over the years, it's been really increasing. And in fact, about 200,000 individuals are diagnosed per year in the state of Pennsylvania. And also, if you look at just this chart of all the counties in Pennsylvania, you'll see that the number of individuals with autism goes from close to hundreds of children to even thousands of children, depending on the county you're looking at. And again, the total estimated cost in total is around $130 million. So what are the areas of research? What are people actually working on, and what do we know about research in autism? One, the genomic technologies. People have been studying or performing research to understand how we can actually diagnose individuals with autism early on. Then there have been looking at the mechanistic implications. How do certain biological aspects happen in individuals with autism using animal models? People are looking at cellular and stem cell models and neurological models to understand the mechanisms associated with autism. And also, especially in the state of Pennsylvania, we have large biobank studies. There are population scale studies actually recruiting individuals, carrying out electronic medical records in understanding what exactly happens in a longitudinal manner over the course of lifespan. And in terms of diagnosis and treatment, what's happening in terms of researchers, we are actually trying to understand and identify biomarkers for early identification of molecular and environmental risks for autism. And at the technology level, there has been discoveries and inventions in terms of generating or developing wearable or tracking devices for understanding behavior and quantify behavior. Well, imaging studies have been extensively done to understand how the certain structural changes in the brain can have its role in early diagnosis of autism. And also at the level of education, there's improved special education stuff that's ongoing. There's a lot of home-based therapies and services for individuals with autism. All these are ongoing, and also clinical trials for certain psychiatric drugs are underway. So there's a lot of emphasis on early diagnosis and potentially for earlier intervention and quicker treatment. So what can we do in Pennsylvania? Well, if you look at any major university in Pennsylvania, there is an autism institute. People are actually working on several aspects of autism, not just biology, but also in human health, environment, and multiple different aspects of it, including precision health and precision medicine. So I also want to really the important point that I want to make is many of the pioneering discoveries in the field of autism has been done by researchers in Pennsylvania. We were the first ones who actually identified deletions and duplications identified in individuals with autism. Causative genes for autism has been identified in Pennsylvania, and also a lot of epidemiological studies have been carried out in autism from Pennsylvania. And not just that, we are not just unique silos working on specific aspects of autism. There are collaborative teams working together to solve this problem. And in fact, when I was chosen to really present this particular topic, I actually shared the slides with several of my collaborators across the state at the University of Pennsylvania, Geisinger, Drexel, and Pittsburgh. So this has allowed me to think about how we can actually really do this as a group. So how is this going to serve in a longer run? So this is almost like the NASA project to launch a man in moon. This is actually helps us actually expand the things that we've identified and used for autism to other aspects of our science. For example, the genomic technologies that were primarily invented for diagnosing autism is now used for the diagnosis of other childhood disorders, and biological discoveries for autism now can be broadly applicable for other neurological disorders, and especially the co-occurring disorders. Medical devices, the computational algorithms that have been used can now be extended to other healthcare purposes as well. And early intervention, personalized management and treatment, and special education strategies that have been developed for autism can actually be used for other broader aspects of clinical outcomes. So improved quality of life for individuals with autism and positive impacts on a broader community of individuals, including those that are caregivers, educators, health professionals, and genetic counselors, are the major impact that this particular proposal can bring about. So I want to really say that we can really do this because Pennsylvania has one of the world's best set of researchers that can actually solve autism. If you really look at all the universities and the researchers working on autism and their collaborative nature, we can surely solve autism in Pennsylvania. Thank you very much.
Thank you. Thank you so much for that presentation. Are there any questions? Thank you very much. Dr. Empey. Thank you very much. Please remember to speak into the mic, because otherwise you can't be heard by the people on the phone.
Good morning. I'm Dr. Mylenda Massart from the University of Pittsburgh, Department of Family Medicine and Clinical and Translational Science Institute, and thank you very much for having us here this morning.
If I could...
From the University of Pittsburgh as well. And we're going to tag team this one, so emphasizing the multidisciplinary nature of the research. And also, you heard quite a bit this morning about precision medicine. We're going to argue that there's no greater application for precision medicine than actually for medications. So many of us are aware of the rising costs of medications. This affects Pennsylvania considerably. The state Medicaid program spends over $3.5 billion on medications. And for many of our constituents, many of the rural Pennsylvanians, everyone across the state knows the burden of having to pay for medications. Simply put, this curve is not sustainable if we maintain on the same breath. Compounding this problem is the fact that medications aren't working for us. The trial and error approach we use for prescribing leads to drug failures and toxicity. Adverse drug events are now the fourth leading cause of death in the U.S. And in about 50% of the time when we prescribe a medication for the first time, we don't get the result we want. These are often therapeutic failures, which of course lead to increased trial and error and increased costs. So what we're here to talk about here today is pharmacogenomics. Increasingly, there's mounting evidence that we can use genetics, each person's DNA sequences, to actually select drugs and medication therapy for patients. Now, at the University of Pittsburgh and UPMC, we're already doing this as part of standard of care. I lead a program where we've been doing this for 4 years in our cardiac catheterization lab. We can show it works. We can show that patients like it. We can show we can get it reimbursed. But there's a lot of other opportunities that are yet unexplored, and all the processes by which we can implement it in cities and in rural populations are left to be decided. And our overall goal is to get the right drug to the right patient. When you see a population like you see depicted here, to understand what's driving that variability and get folks into the right bins before we give the first dose of the first medication.
So often people think that these medications are highly specific or costly oncology drugs. And the truth is there are actually almost 300 medications that already have FDA labeling to consider some form of pharmacogenomic testing for prescribing. And these are actually medications that I use every day and that my fellow family medicine physicians use every day in our clinic treat routine cardiovascular disease, depression, you name it. These are very common and very frequently used drugs. And they impact nearly everyone. Our own study here at the VA administration in Philadelphia showed that out of 77 million veterans, 99% of that population have at least one genetic variant that impacts prescribing. So if you could imagine, that's nearly every single one of us in this room would have one genetic variant that would impact potentially the medications that we're taking. And how many of us have been on medications? How many of us have been on medications that have failed or caused adverse side effects and contributed to major complications? And our patients really want this. My patients ask for this to be integrated into their care already. They're very aware of genetics and the advances of genetics and the integration into their health care. And 1 out of 12 Americans have already sought direct-to-consumer testing through companies like Ancestry and 23andMe. And we know that pharmacogenomic results are actually going to be released by these direct-to-consumer companies as soon as potentially later this fall, which means as a clinician, if you haven't already had a patient bring these types of test results to you or ask for them to be done, it's going to happen within this next year. So at the University of Pittsburgh, and as we've already heard today, I think there's a huge emphasis in our state on precision medicine. Pittsburgh is very honored to be part of the National All of Us Research Program through the NIH. We were actually the first site to go live over 2 years ago already. The national site went live last year, and pharmacogenomics and returning pharmacogenomics is going to be a high priority within that study. Additionally, at the University of Pittsburgh, we have multiple other studies.
Well, I lead a program called Pittsburgh Pharmacogenomics, which is envisioning testing an entire population, a large population, 150,000 patients in Western Pennsylvania, and offering testing as part of a research study that could help us inform practice, return results to patients and providers. And we're seeing a great response to this. We have already 4,000 patients who have come to us and elected to participate without any additional remuneration, just to be involved in the study where they can learn more about their medications. Importantly, it's not just us. If you look at the other emblems here, yellow logos in the state here, in the middle of the state, Geisinger has a very significant genetics initiative called MyCode. We've already mentioned one of the VA's projects. The VA in Philadelphia is launching a national pharmacogenomics program in mental health. And then the other institutions, Penn State and Penn itself, also have just formed Institute of Precision Medicine organizations in their own groups and have active research programs in pharmacogenomics. So I would argue that Pennsylvania actually is already a leader here. We have the infrastructure in place. We have the patients that demand this. It's just about how we pull groups together to understand how to do this effectively, how to do it smart and a cost-effective way, and to be ready for when our patients come to us, and when our payers have questions about when they should be paying for things, and then how to support our providers in the way in which we're doing this. So in terms of research priorities, we went through the list and sort of started brainstorming all the different ways this could possibly be implemented, and we broke them into biomedical research topics, health services research, and clinical research. So in terms of the biomedical sciences, we can start understanding specifically what populations are carrying what variants, to understand what ethnicities and what populations may be more targeted for testing and where we can offer the biggest impact. We can understand more discreetly what medications patients are on and where we can understand these gene-drug relationships to create targeted interventions where we can get the most benefit involving our overall care. There are already, as was said, 300 medications, but there's a lot more opportunities for other medications coming up. We have about another 3,000 to 4,000 other associations that are early on in evidence. They are just waiting projects to be able to validate the clinical associations. There's a groundswell of support around here, and there's more and more genetic information is available to make these associations. And then increasingly, we're not doing these large, expensive RCTs, or randomized controlled trials. We're actually conducting pragmatic, real-world trials in our populations, like the one I mentioned here in Pittsburgh, and there's a tremendous opportunity to do this. Because again, patients are coming and demanding it.
On the clinical side, we really need to understand how does preemptive testing, which means obtaining testing before needing to do the prescribing, how does that impact our clinicians if they have that data available to them at the time of prescribing? In addition, How does this impact our patients' compliance? Will our patients actually be more compliant with their medication if they understand that they actually have genomic variants that favor that specific medication? Furthermore, how do we better understand how our genetics impacts our outcome with our medication treatments? And finally, how do we teach and educate our patients to use this data and to use it wisely? So getting back to us here in the room, if any of us have engaged in direct-to-consumer testing, when you get that pharmacogenomic data back in your email at 11 p.m., how are you going to know what to do with that data and not to actually stop your medication on your own, and how to share that with your primary care provider for proper integration into your healthcare?
And then finally, for health services research, there's a number of questions we can go into here. Specifically, the preemptive pharmacogenomics questions. It's a lot harder to do something after the fact and then try to find the patients and the scenarios in which we can call people back and change therapy after we've already spent money on it. Preemptive testing is the way to go, whether it's something we do at birth and carry that along with us, or when we have a triggering health event, like a new heart attack in our particular program. So studying that and when best to apply it is strategic. Understanding sort of the optimal methods of educating providers. We do a pretty good job, I think, in the School of Pharmacy and the School of Medicine at the University of Pittsburgh. But I'd ask yourself, how many practicing providers in the state of Pennsylvania have had a robust genetic education in their training? It's only something that we've been doing really aggressively for the last 5 to 10 years, which means we have a lot of providers that feel paralyzed without this information. And we think we need education programs to make this really implemented effectively in practice. And we think it's beyond the urban settings, in the rural practices, the community pharmacies, the independent pharmacies that are talking to people about medications. Whether you're in Pittsburgh or Scranton or somewhere in between, or over on the eastern side of the state, I think there's tons of opportunities, whatever practice setting you're in. And then finally, I think there's a tremendous opportunity for technology innovation. Genetic results are done in a single lab, and they just follow you around. They're lifelong results that impact your care. We have to think about whether that means apps or more interoperable medical records, but there's things that we can do together as organizations to make sure that these data make the impact they should in our overall care. So in conclusion, we think there's a tremendous opportunity thinking about precision medicine, specifically for medicines. We know what's happening. We know all of our institutions across the country are already spinning up efforts because they think this is the way healthcare needs to go. And most importantly, we know our patients want this. If we can get Pennsylvania to better medication outcomes by reducing the trial and error, we can make a significant impact, and we can do this quickly. Thank you.
Thank you very much for that presentation. Are there any questions?
Yes, Dr. Levine, it's Dr. O'Donnell. I have a couple of questions and a comment. On slide 88, there is a graphic. There's a sort of the universe of pharmacogenomic PGX model. Then in the middle, it says PGX testing, and then it breaks down into 4 different groups. Where it says PGX testing, essentially a black box. It doesn't really tell me anything about what's involved in the testing. So I have a number of questions related to this include, how do we know that this even works? What has been the methodology for testing that the testing works? We've all been witness to some of the things that have happened in other kinds of testing that have had tremendous implications, mostly having to do with I'm blanking on the name of the big scandal that came out of Silicon Valley. The woman who created the
Theranos.
Thank you, Theranos. So how do we know that little black box is not another Theranos model? That's number one. Number two, one of the 2 presenters made reference to 23andMe, which I assume means that is some basis for the PGX testing approach. And I would just like to point out that there have been a number of shortcomings that have been noted in a number of publications in 23andMe, particularly with respect to breast cancer genetics that have not been perceived, picked up, and applied appropriately. So while theoretically this sounds like a great idea, I just wonder about, how do we know that this actually works? And I'd be pleased to look at, if it at a later time, if you'd just like to send a bibliography of research articles that demonstrate that this actually works, I'd be interested in that. Thank you.
Thank you so much for that question. We'd be very happy to provide that reference list. In specifics to your testing question, you're right. Some of the testing that's been in the news is much less regulated, some of the direct-to-consumer testing. But I want to emphasize that clinical-grade testing for genetics that we do in regular hospitals under CMS and CAP/CLIA regulations that are governing labs are accurate, and there's no reason for the public to question the veracity of testing that's done within a clinical setting. Further, the associations we mentioned, the up to 300 medications, are in our FDA-approved guidances and labeling. There are active black box labeling instructions that say if there are genetic data available as measured in these settings, we must be using it to tailor care. The only real question is, when will the genetic data be available in care? So it's mostly a logistics question and a payment question. But to address your question specifically around the references, we'd be very happy to provide that. And then maybe Melinda can talk to the 23andMe question specifically.
Yeah, and I apologize if sorry, go ahead.
I'm sorry, I missed that last comment.
I was just transitioning over to Dr. Massart to talk about the 23andMe.
Okay, thank you.
And I apologize if I created any confusion by referencing them. Specifically, I'm referencing them because they are 1 in 12 people in our state are purchasing their product. Their product, while it is not adequate for clinical decision-making, will reach the hands of our patients in this state. There are actually very specific FDA guidelines on what can be done with that data for the utilization in clinical decision-making when it comes to prescribing. And what needs to happen as of right now is that data needs to be validated in a clinical test. So one that is run, as Dr. Enzi mentioned, in a CAP/CLIA lab at one of our standardized testing facilities. So I hope that makes some clarification around there's no intent to use that company in our proposals or concept of proposals.
Thank you. I appreciate the clarification, and I'll look forward to reviewing the bibliography that supports this scientific approach to medication. I would add one comment to the, and I apologize, I don't recall the names of the two presenters, but the gentleman noted that the public has no reason to question. I beg to differ. The public has not only reason to question, we give them reasons every day to question lots of stuff, but they have an obligation to question. So I think you cannot, I think it's a mistake to assume that the public, the patient, the folks that are being treated shouldn't question, and this is not a matter of importance. 23andMe, although a great indicator of people's interest in genetics, really has a heck of a lot more to do with understanding who they are in terms of cultural and social phenomena rather than diseases. And in fact, many people are afraid to find out that maybe they have a predisposition for some very bad disease unless they're prepared for that information. So I would be a little bit cautionary in using that as an indicator of our patients want it. What the folks that are ordering that want may be utterly inconsistent with what's being presented here. That said, it's not to say it's a bad idea. I would just like to be reassured that the science is really there. So thank you for that presentation.
Thank you very much for your comments. And I encourage our patients to question all the time. I was just referring to the fact that I think we have good data to support the trustworthiness of those particular tests.
Yes, thank you so much.
Thank you. Let's move on. Dr. Kelly.
Wonderful. So while we set up the slides, I just want to introduce myself. I'm Deb Kelly. I'm very new to the Pennsylvania area. I was recruited.
Much louder.
Hi there, how's that? It's like some feedback on the mic or something suddenly. Maybe it doesn't like my baritone. But nonetheless, I was recruited to Penn State from Virginia Tech very recently in the last year or so. I had just finished my fellowship training at Harvard Medical School, and I was a professor at Virginia Tech for about 8 years, where I established a robust research program. And I lead a new center now, and our funding from the National Cancer Institute is valued at about $7 million, and I manage this program moving forward. And our primary interest in what we study and research is breast cancer. So do we have any women in the room? Or do we know anyone that knows any women? All right, this is for you. So what we're interested in doing is creating a cancer-free Commonwealth. It's a lofty vision, but we have to go about this in a very particular way in which we can outsmart cancer cells. So first slide, please. So Pennsylvania is doing really bad in fighting cancer, I'm sorry to say. Where I come from in Virginia, we're actually doing a lot better. As indicated on the slide that was published by CDC in 2012, as you can see that I'm trying to highlight here. As you can see with the red dots, Pennsylvania joins the other partners in the Northeast that doing really bad at fighting cancer, and that's got to change. What keeps me up at night is why is cancer still a thing, and I'm sure many people feel the same way. Next slide, please. If we look at more specifically what keeps people up at night in the Commonwealth of Pennsylvania is invasive breast cancer, and that's my area of specialty and what I'd like to speak to you a bit about today. So invasive breast cancer is a ticking clock in the mind of women who have previously been treating with breast cancer. If you woke up this morning and you didn't think about whether your cancer is coming back, you're one of the lucky ones. Because there are many women that woke up around the Commonwealth this morning that did think about this. Next slide. And so what we want to do is we've identified areas within Pennsylvania that are most at risk for developing invasive breast cancer. We want to understand what molecules in those areas in those people are actually causing recurrence and causing the disease to proliferate and spread across the Commonwealth. And when you look at where Central County is positioned clearly in the middle of the map of Pennsylvania, where Penn State is located, I think we're at a good position to help establish an RFA and lead a research initiative to do that. So I'd like to just disclose some of my information about how I think we can have that happen today. Some of the regional areas that are in the top left of this map, you can see are a bit more rural. And when you sweep around down to the Philadelphia area, we have a much more urban population, which we have a lot of minorities and people with mutations that are carried on, particularly BRCA1, which is what I work on. That's very heavily investigated at the Abramson Cancer Center, as well as the Oshkosh Jewish population, another research interest in a growing area. So you might hear about these cases of these celebrities that are getting changes in their bodies, they're taking these double mastectomies at the risk that this BRCA1 is going to give them cancer. Well, it's a very smart thing to do. Why should women have to manipulate their bodies when medicine fails them? I think this is absolutely unacceptable, and we have to stop that, and we have to do something to intervene with that. Next slide, please. So, what has MedPen done that we're successful at, and we think we're so smart at? Creating all these devices. We've been able to create smart devices that can put all of the information that's physically available on a chip in your pocket. But next, we can't kill these cells. Why can we not kill these cells? Why is it we can create all these smart devices that inform us of everything that's going on in the world? Unfortunately, reading tweets from people, for instance, but we can't understand what these cancer cells are tweeting out or what they're communicating on a daily basis. We have to dig into the molecules of how these things are communicating, how these cancer cells are living in our bodies. What's really going on at the root cause of this, and how do we get at this? So where medicine has failed us, I think technology can help partner with medicine to push us along, push us to the next level, use technologies that are being invented all across Pennsylvania, partner the universities together to develop these technologies and partner these with pharmaco companies, different drug companies that are about in Pennsylvania, as well as different industries that we can push this to the next level. Next slide. So what I'm proposing is to create a cancer-free Commonwealth. I think we have to do this. As Pennsylvania is right up lumped into the area with the other states in the Northeast that are also failing at curing cancer. Let's be the leaders in creating a cancer-free Commonwealth. Then adopt that plan of creating a cancer-free Commonwealth to other states and really eliminate this from our population. We're not developing a better molecular management plan to do that. So Areas in which we can, I see, immediately improve parent technology with medicine to do so are to understand what's going on with these pre-survivors. People who have these genetic mutations don't get cancer. For people who have these genetic mutations that are at risk of getting cancer, how can we intervene and give them some sort of therapeutic intervention such that cancer, when it does form, becomes more manageable? Is there something we could do with these survivors that fought cancer with the clot going off in their head before it's coming back? Is there something we can do to develop these better molecular management plans? And that's on aim 2 here. And the way you do that is to dig deeply at these molecular culprits at the root of cancer, what drives them and allows them to come back. And I'm not talking about all the signaling pathways that people have investigated forever. I'm talking about looking at the molecules, using high-powered materials and technology to look at these molecules, put a face to them, see what they look like in 3D directly from patients, and you're like, oh, there's the culprit. Hit it with this drug, or do something to intervene with it that way, and then have a better molecular management plan, which was done with HIV. We haven't cured it. We've managed it better. People have happier, healthier lifespans that we ever thought were possible before we all band together to fight HIV. We have to band together to do this as well. So the next slide. This is my plan to create a cancer-free Commonwealth. We have to use high-powered imaging technologies. What I have shown here is one of my babies. I do what's called cryo-electron microscopy, and that allows us to see down at the level of atoms. Cryo-EM is a technology for which my colleagues were awarded the Nobel Prize in 2017. And they did this based on molecular structure. How can we take these individual proteins, look at them, put a face to them, point out the wrong problems in them, and then create new therapies in a more informed way rather than random trials, rather than screening a genome and saying, you have this gene, you might get cancer or not. Women are faced the consequence of molesting their bodies or not seeing their children grow up, unacceptable. 50-50 chances of, it's a 50% higher propensity for women with BRCA1 mutations to develop cancer. That's a flip of a coin. It's not exactly the genes that are causing problems. There are other players inside the cells. And the BRCA1 gene codes for the BRCA1 protein. We're the first people to ever see what the BRCA1 protein looks like. And since my cancer, no one's seen what BRCA1 looks like before we published a paper over here recently out in the States. So I think that we're located in the hub of Pennsylvania. We have to be the leaders in creating a cancer-free Commonwealth, and then we can create a cancer-free society. Use these molecular management plans by looking at the face of cancer. These culprits, some of the most popular molecules, have no face. Let's put a face to them. Let's look at them in 3D. Let's design drugs against the things that are going on with them, more informed, rather than random screens or to try and understand this mutation might. We want to say this mutation will. And how can we combat it? Before it creates problems, can we better the lives of people with these genetic propensities through better molecular management plans in a more informed way by putting a face to these using high-end technology and the type of atomic imaging that we're at Penn State, and pair these with the other healthcare partners, the BRCA1 Center at UPenn, and deliver these and get these samples from these rural populations and really make a difference in these people's lives to create this cancer-free Commonwealth. We have to outsmart cancer because right now it's outsmarting us, and that's absolutely unacceptable. I'm going to end here. I don't know how I'm doing on time, but I'm happy to entertain any questions for the remainder of my time if there are any from the audience or on the phone call.
Thank you very much for your presentation. Are there any questions?
Excellent. Clarity is my specialty.
Thank you. So while our presenters are here, does anyone, Dr. Davis, or does anyone on the phone have any questions for any of our presenters?
Dr. Levine, I actually have a question for Dr. Torren Finkel, if he's still on the phone or available.
Yeah, I'm still here.
Hi. I wonder if you could say a little bit about, I'm just rolling through your slides again and looking for the slide that I wanted to raise with you, where you talk about, it's slide 65, I think it is. Just a second. Yeah, 66, where you talk about IL-6 levels correlating with frailty, mortality, and morbidity.
Yeah.
How often are primary care providers or geriatricians actually measuring for IL-6 in their routine practices?
Zero.
And zero. Okay.
Zero. I mean, it's very expensive. We it's right now it's $400 or $500 a test, unfortunately, and it's just not routinely done, in large part because although, it's obviously a very strong predictor and correlate, there's been no proof that lowering it is beneficial, and that's sort of the basis for this trial. The NIH sponsored a trial recently called the ENERGIZE trial to try to lower IL-6 using either fish oil or losartan or a combination thereof. And unfortunately, none of those combinations or individually was actually able to lower IL-6 levels in patients. So as of now, there's been no way to lower it, and therefore no way to prove that it really causes versus correlates. And because of the cost of the test, it's not routinely done. Although, as I said, epidemiologically, in studies, it's clearly the best predictor we have. So in terms of who's going to do well and who's not going to do well. But right now, it's not actionable, and it's expensive.
So the study that you're proposing looks for it. I'm trying to understand what the interventions are. It looks like you're measuring for it.
No, so there turns out there are very potent ways to lower IL-6 using monoclonal antibodies. Those therapies have been used for conditions like rheumatoid arthritis and psoriatic arthritis, for Crohn's disease. So those antibodies exist. Many of them are FDA approved for those hyperinflammatory conditions. They're very potent at lowering IL-6. We're going to be giving elderly patients roughly 1/5 the dose that's given for those types of conditions that I just mentioned, like rheumatoid arthritis. They're monthly injections. They're very potent at lowering IL-6 levels based upon the experience in these other conditions. And the question will be, if we do that in these patients over the course of the year, do we see improvement in their ability? The patients we're measuring will have baseline elevated IL-6, and we know from our experience that those patients will be able to walk across the room, but they have a little difficulty doing that. They have other issues. They're in that sort of pre-frail category. We know that they'll have about a 25% incidence of being admitted to the hospital over the course of the year. They're sort of failing, and if nothing is done, they will continue to unfortunately get worse. And so the question is, can you give them these antibodies at lower doses that have been shown to effectively lower IL-6, lower the inflammatory state in these hyperinflammatory conditions like rheumatoid arthritis, and will that be beneficial to them?
So I understand. So and on slide 67, you are proposing 50, and I understand that this is not a proposal that's been submitted. So it's just really talking points for the concept. But to that end, so you're talking 50 participants in equal groups of 25 each.
Right.
So there would be 25 groups of 50?
No, I'm sorry. 25 patients getting placebo, 25 patients getting anti-IL-6 antibody. It's an expensive it's an expensive proposition. It took us about, the antibodies themselves are expensive. We were managed to get a company to provide the antibodies for free for the study, and we've managed to get philanthropic support to support the trial. And the hope would be that, if it's successful, that, we either through, something like the Cure Network or through traditional NIH funds, we could show that this strategy might be very interesting to pursue in sort of larger numbers. We're sort of powered, we think, in that small number to look at our primary endpoint, which is low-level fatigability, basically how much oxygen it takes for these patients to walk sort of at sort of a very sort of comfortable walking speed on a treadmill. That's sort of our primary endpoint. But we're looking at body composition, cognitive function, depression, muscle strength, a variety of vaccination response to influenza. So really a variety of age-related endpoints in this small group of patients.
Thank you. I don't want to use up everyone else's time, but I appreciate the clarifications, and it's an interesting concept and study. If you have a bibliography you could share, I'd be happy to read more on the subject.
Absolutely.
So thank you very much.
Right.
Thank you. Are there any other questions for any of the presenters?
This is Michelle Masucci. I want to follow up on the last set of questions on the same proposal or the same PowerPoint for Dr. Finkel. So sorry, I hear some feedback. One of one of the tasks that we are going to have in our deliberation after the break is to figure out how to cast an RFP that is broad enough to be inclusive and yet still get at the specifics of a particular theme. And so I'm just wondering if you could comment on, would your overarching theme be aging? Is it inflammation? Is it immunology? Like, what would be the health anchor that would be the best, umbrella under which this would come? And maybe it is aging itself, but I'm trying to figure out, how would we construct an RFP that would be broad enough, but yet also be inclusive to this particular concept?
Yeah, so I mean, on that slide where I showed this sort of circle, sort of the hallmarks of aging, I just brought up the inflammation part because that is the sort of trial that we're launching here. But I think there are other things going along in the state, and it would really be this idea that, we understand a little bit now, or a lot now, about the basic biology of how and why we age. And it's basically trying to leverage that information, both at the bench of the basic science. I mean, it could be as broad as, the basic sciences in terms of trying to extend that knowledge and understand what are the regulators of human aging, but also translating those insights into either clinical trials or new therapies that leverage that information to develop new therapies for age-related diseases. So it wouldn't be studying Alzheimer's or cancer, but really what are and I'll give you an example that my lab, again, I don't want to be too self-referential, but we study this process called autophagy, which won the Nobel Prize a few years back. It's the sort of quality control mechanism by which you get rid of damaged proteins and organelles in your cells. It's a process that declines as we get older. And so that's a process that's very druggable and that, we could stimulate with small molecules. And a number of companies are started to try to do that. And that allows you to get rid of protein aggregates in your cells that accumulate. So those aggregates occur in Alzheimer's disease, they occur in Parkinson's disease, they occur in frontal temporal dementia. So it wouldn't be any of those specific diseases per se, but it would be potentially grants that sort of are at those basic mechanisms of aging that sort of permeate across a variety of age-related diseases. And whether that's at the bench or whether that's in the clinic, I think the RFA could be written broad enough or whether it's, involving pharmaceutical companies, or I don't know if that's part of the grant, but involving drug development studies that will begin to develop new molecules. In fact, we are just in the process here of starting a company based on that concept of two small molecules that we hope to take to the clinic in the next year or two, that again go after these basic biology of aging and that treat really, we think, a variety of age-related conditions. So I think, to me, I don't want to make it about what we do, but really I think there's a lot of, if you look at that hallmark slide, there are a lot of basic biology drivers of aging, and it'd be really to understand those better, to leverage those insights to begin to develop new therapies for age-related conditions. And I think some of those could be clinical, it could be translational, or it could be basically on that theme.
Thank you so much for that clarification. That's exactly what I was trying to get at.
Thank you. Just as a point to also clarify, pharmaceutical companies cannot apply for this funding.
Okay, that's good.
They have their own money.
Yeah, no, sure, absolutely. But there's a number of academic groups trying to do this. I know that in the Philadelphia area, and then I said we are as well. So certainly those types of things could be facilitated.
Great, thank you. Are there any other questions? All right, so we are running 15 minutes ahead of time, which is good. I do recommend that we take a break. So why don't we? I guess on the phone, would it be better to just put it on mute? And I guess you can hang up and call in, but pay money, take chances. So hopefully you're in now, so please stay in. And I would like to thank all of the presenters for coming today, and some from quite a distance, and with all of you from coming. And so you are free to leave, because we won't be answering any more questions.
Everyone here signed in, though.
Yeah, everyone has signed in.
Yeah, make sure
we'll be coming back at 11:30 to reconvene for some review of our guiding principles. Excuse me? Okay, so we'll see you all at 11:30. As far as we know, as far as I can tell, I'm here. So Rachel Levine is here. Dr. Davis is here.
Correct.
Dr. Feinstein, are you on the line? Nope. Dr. Levine, Dr. Arthur Levine, are you on the line?
I am.
Great. Welcome, sir. Dr. Masucci.
Yes, I'm here. Thank you.
Dr. O'Donnell.
Yes, I'm here. Thank you, Dr. Levine.
Dr. Parmachek.
I'm here.
Dr. Tombrose.
Georgina.
And Senator Vance. Senator Vance, are you back on the line?
Yes, I am.
Thank you. All right, so we're all back. Thank you for the break. I think it was really important. And I thought the presentations were great. I thought they did all a fantastic job, lots to think about. So, our next order of business is to discuss the non-formula research priority, or priorities, for 2020-2021. And so I'm going to talk about some specific issues in terms of setting priorities. This was included as Appendix C, and so let's review some of those. The department has the responsibility to establish, in conjunction with this committee, the research priorities. Quote unquote, those priorities shall be reviewed annually and revised as necessary. And this means the department does not have to change the priorities, but we can and usually do. The Act states that the priorities shall include the identification of critical research areas, disparities in health status among various Commonwealth populations, expected research outcomes and benefits, and disease prevention and treatment methodologies. And the focus of the priorities, of course, must be on research. In developing these research priorities, the National Health Promotion Disease Prevention Objectives established by the U.S. Department of Health and Human Services as applied to the Commonwealth shall be considered. Thus, for example, Healthy People 2020 and soon Healthy People 2030.
Dr. Levine?
Yes.
This is Peter. So I got disconnected, and so I missed the roll call. This is Peter Tombro, so just wanted you to know I'm on.
All right. Thank you, sir. In 2003, the committee developed 5 principles to guide its decision when recommending non-formula research priorities, and these are included in the Setting Priorities document. First principle is that the research priority shall address a health-related issue that has significant impact on the health of Pennsylvanians. Funds should be spent on research that will benefit the greatest number of Pennsylvanians, and these decisions should be driven by data documenting the need within Pennsylvania. The second principle is that the research priority should place emphasis on a health-related issue that disproportionately affects vulnerable segments of the population and disparities in health status among various Commonwealth populations. The third principle is that the research priority should be inclusive of all populations that are at high risk for the health-related issue, instead of being limited to specific subpopulations. Health conditions that only affect one high-risk group should not be the focus of the limited research dollars. Focus should be inclusive, allowing for different research projects to address different at-risk populations. The fourth principle is that the research priority should focus on studies with the potential for prevention and control, including the identification of risks and etiology for a health-related issue, and have the potential for public health practice and population-based applications. The fifth principle is that the research priority should promote collaboration among Pennsylvania institutions, including smaller colleges and universities, and other non-academic medical centers, as well as the major research institutions. In terms of conflict of interest, in a prior meeting, an inquiry was made by a member regarding the issue of the potential conflict of interest within the community, and thus the conflict of interest policy was posted on the site and is Appendix D. Another thing to think about are what have been the priorities to date. And so in Appendix E, you have all of the different priorities since the inception of the program, and Alzheimer's is the last one. So really the objective for the remainder of this meeting till 1 o'clock, I guess it could go later, but hopefully not, would have the committee identify the non-formula priority. And I will, at the end, I'll ask committee members to identify who will volunteer to draft a brief language for the final priority. So we're going to open the floor to discussion. I think maybe we should take some turns, kind of go down the list for people to kind of talk about what their thoughts are. Then we can have some open discussion. And, hopefully we can identify the priority today. I guess if the committee needs time to continue to discuss, we could, finish the discussion. If people aren't ready to vote, then we can do it by email. But if we could do it today, it would be better. So I guess as we go by each committee member, could you propose one or two of the priorities and sort of why? And maybe we can ask a couple questions, and then we'll have further discussion. Does that agenda meet everyone's satisfaction?
Yes.
Yes, Dr. Davis.
So before we start to talk about our selections for topics that we may have heard today, I just wanted to bring up another item. We probably talked about this in the past, and I'm not clear at this point how it might affect some of the topics that we've heard. But one of the issues that, for me at least, came up during the presentations were the background of funding by of some of these topics by government agencies, particularly NIH funding and the like. And so as we go through our discussion, I have some questions about whether or not, at least at a national level, some of these topics rose to an importance such that areas of topics presented might well fit into categories that the National Cancer Institute, NIH, and the like might have interest in and might already have funding that has been distributed, not specifically to some of the people presenting, but would be eligible for outside government-supported funding. I just want to raise that issue as we start to talk about topics.
Thank you, Dr. Davis. There was another comment?
Yes, Dr. Levine, it's Dr. O'Donnell. I just have a question, if you could clarify. So the topics that are under discussion for approval either today, if we can agree, or at some later time if we can't, are the 7 topics that were presented by the various presenters. Do I have that right?
That is correct. So so some of them had talked about their work, and again, this is not their work that would potentially be funding. It is the topic. So let me sort of outline what some of the topics are. Prevention and management of cardiometabolic diseases using team-based science, innovations to increase vaccine coverage and reduce vaccine-preventable disease burden in Pennsylvania, genes, environment, and age-related chronic disease, geroscience, unlocking the secrets of aging to treat chronic disease, autism, pharmacogenomic testing to improve medication outcomes, and outsmarting cancer cells. So those are the topics.
Right,
those researchers might or might not apply as part of the RFA, and they might or might not get funded.
Yes, I understand, and I appreciate your clarification. I was able to follow pretty closely, in no small part because your staff did such a great job assembling this. So I was able to separate out each of the topics that you just mentioned. I would just point out that on the one topic where I queried the presenter on pharmacogenomic testing, I'm a little bit, I remain a little bit skeptical, but that's just me. And I actually wondered if I can ask both Dr. Levine and Dr. Parmachek. I mean, do you guys see this in the practice of patient care? Mike, in your practice, for example, do you do this kind of thing? And Dr. Levine, is this something that happens in your world with clinicians?
And so let me take a shot. The answer is absolutely yes, and it's growing. The example that I can give right out of the, that everyone's aware of is clopidogrel versus prasugrel, which is about 20% of patients about have a mutation that predicts they won't respond to clopidogrel correctly with following a PCI or procedure like that. So we actually have a point-of-care testing device in the laboratory to test who has that mutation so we can put them on prasugrel. The reason you don't put everybody on prasugrel is it's much more expensive. And so from a cost-efficacy standpoint, that's one of the proven examples. There have been a number of others that, frankly, have not worked out as well, but that's why they require further investigation going forward.
And who is speaking?
That's Mike Parmachek from Penn.
Thank you. Thank you, Doctor.
Thank you.
This is Art Levine. Since I was asked to comment, let me add to what Dr. Parmachek just said, because we did much of the early developmental work on clopidogrel here. But in addition to all that Mike has just said, I want to point out that when we now look for the genomic variant that makes the difference in the metabolism of these drugs and act on it accordingly very quickly, the hospital readmission rate for a second heart attack, and in fact the lethality of a second heart attack, goes way down. So we're talking about sequence analysis and identification that now is a matter of living or dying. So that's simply the latest wrinkle in identifying who should get a given drug and who shouldn't get it. I want to point out that warfarin has a half-century history, and the FDA, for much of that time, has had drug warnings on the inserts that talk about not giving the warfarin to people who can't metabolize it and therefore for whom it won't have any activity. That's true of warfarin. It's also true of the anesthetics that can compromise the lives of people with heritable malignant hyperthermia. There are many other examples as well. So although, as Dr. Parmachek pointed out, that close alignment of living and dying hasn't been true for every drug that we've interrogated. It's been true for most. So we're not talking about anything trivial here. I'd also point out that if you give the wrong drug to the wrong patient at the wrong time, you're wasting an incredible amount of money as well as compromising, potentially, the patient's life. So in an era when we're very concerned about drug pricing, we certainly should realize how much money we can save while saving lives by, once again, using the right drug for the right person as determined by their genetic susceptibility.
And I agree with everything. And as usual, Art says things much better than I do in terms of making those points. But just to expand even further, with the increased, there was some discussion early on about 23andMe and a whole host of these other lay public genetic testing services, but more importantly, the ones that we're going to be rolling out at medical centers across the country. We already know that there's a host of these mutations that we really have identified, and we can do the studies, and this RFA would allow us to do those studies to really see if there's benefit from adjusting therapeutic strategies based on the genotype that are identified. I wholeheartedly, if anyone came away thinking I'm not supportive of this, I am very supportive of this.
I want to add my voice to this conversation as well. This is Michelle from Temple. I think both of the two explanations of this are really, really helpful to understanding the potential impact of this particular thematic area of research. I would add that there's growing evidence as well about how the ethnicity and racial background of individuals needs to be considered in terms of the genetic markers that might exist when we develop therapeutics. We also have research going on at Temple that shows us that there are biomarkers that are more prevalent in some backgrounds than others, and I think that would help to address our mandate that Dr. Levine pointed out, which, by the way, I thought was really helpful, to make sure that not only would the theme be applicable to a large population, but also start to get at health disparities issues. And I think that that's something that we're right on the cusp of in the technology being able to do a better job of. And so we think that would be useful for us as well.
This is Dr. O'Donnell. I just want to thank both Mike and Art for assuaging my concerns on this subject, and I would be in favor of that being one of the choices. I think my second choice would probably be the geroscience approach to. I just am impressed by the idea of looking at cell failure as it relates to aging, and that spans multiple diseases, which I think lines up pretty nicely with some of our obligations in terms of what we fund. So I think for me, those are having my concerns assuaged on the one and being impressed on the other. I would be that's where I would go if we were voting today.
Thank you. So let's go down the list. I'm going to go last. So it's going alphabetically. Dr. Davis, what are your thoughts?
Yeah, the two areas that I made a list of the areas we should be thinking about in terms of topics, in terms of Pennsylvania population and large numbers and vulnerable populations and all of those other kinds of things. But I was impressed. Certainly, the pharmacogenetics was a nice topic. The two for me are vaccine and the presentation on cancer cells. I thought that latter presentation, and I haven't seen her bibliography yet, but it sounds like there is a pretty good start at trying to look at cells at a very, very low level in terms of figuring out what their properties are and how we might better address those cells within an organ. It certainly affects an awful lot of women, certainly in Pennsylvania. It probably has some prevalence and prominence in terms of lack of follow-up for disadvantaged populations. The vaccine story is one that we all know an awful lot about in terms of issues that it has raised, in terms of how we are able to better address things that we have ways of approaching and other ways of thinking about how we might utilize them. So as we go through further discussion, those would be my two.
Thank you. Dr. Feinstein. Although she's not here. Dr. Arthur Levine.
Yes. The two that I would support are the two that, in fact, we submitted. And I apologize for having been a couple of days late in getting them in. But I do want to point out, because I think this was discussed this morning, that there was nothing that has ever precluded the committee members themselves adding other ideas if they felt they had substance. And I was pleased already to hear that there is support for the notion of pharmacogenomics. And now I want to talk a little bit about aging, which would be the second theme that I would support. We spend a lot of money and we invest a great deal of thought and effort in exploring diseases that we get as we become older. And in fact, most of the health burden in this country, if not the world, and most of the economic cost of that burden relates to the diseases that we get as we age. But what we're missing is a true insight at an environmental and molecular level of the quality of life when we age to begin with, because the diseases are all secondary. What's primary is the biology of aging and the biology of longevity. So, for example, we know that there probably are clear genetic differences between people who look old and function old physiologically in their 60s and other people who are still thriving and going to work every day in their 80s and 90s. So that's a very broad spectrum. And we don't, although we have a hint at genetic differences, we're far from really understanding that difference and manipulating it if we can, not to make people live longer, but to have a far better quality of life as they age than they may otherwise have. In other words, the more we understand about the environmental and the genetic roots of the biology of aging, the better we're positioned to prevent the diseases like Alzheimer's and cancer that occur simply as a consequence of our getting older. So those are the two themes that I would propose. With regard to cancer, although the percentile success rate at the NIH is now 17% and a little less than that for the NCI, the proposed appropriation for this coming fiscal year is a very good one, a very healthy one. We just hope that it's endorsed by the president. But assuming that will happen, there's plenty of money available for the kinds of studies that have been described with regard to cancer. And I would also point out that there's even a better technology for true ultrastructural interrogation of single cancer cells than cryo-electron microscopy. It's tomographic cryo-electron microscopy, and which is why we have invested heavily in such an apparatus. So even having made that investment and wishing that I could get a return on my investment, I wouldn't expect anyone other than the federal government to support that research. As far as vaccines go, I see this as a societal issue, not as a research issue. When we have an anti-vax movement in this country and notable people, including at one point our president, aligning themselves with the anti-vax movement, then we're talking about a profound societal, ethical, and political issue, not a research issue.
Thank you, Dr. Levine. Dr.
You're
Masucci.
welcome.
Hi, Dr. Levine, I couldn't agree more with your statement about the vaccine issue. Thank you for sharing that perspective. My preference changed as a result of these presentations, so I thought I might offer that comment simply because, it does speak to why it's important to actually hear, how it is people are conceiving of the concept that they're presenting. So initially, I was focused in on the cardiometabolic disease priority for a number of reasons, not the least of which is that, we understand that there is this conflation of, again, I'm not an MD, so you'll have to forgive me that I'm not speaking in those terms, but there's a conflation of different conditions that are all, I guess, co-present in an individual, and I think that was what I initially thought would be coming out of that. But in the end of the day, I'm more convinced by the aging and related to chronic disease theme. I think it addresses the needs of a very large and growing set of concerns. I think that if we can back up to a broader approach to it than the specific research that was presented, so really thinking about the basic biology of aging, which I thought that diagram was very helpful, and if we write that RFA in a way so as to be a bigger tent, which is kind of the comments that I was getting at in my question related to that theme, then I would be supportive of it. But I think the devil would be in that detail to make sure that the way the concept is written is broad enough to ensure that we have the ability to evaluate a diverse array of research topics on that theme. My second choice is the pharmacogenomic one. But I have another question related to that, which we don't need to discuss right at this moment, but I think would need to be better addressed. I thought I heard you say, Dr. Levine, that drug development is not a part of this, and we're not allowed to divert funds to that. So it would be just clinical, and yet I do think that some of the really important work to be done in this area might be in the drug discovery realm. So I don't know if we want to comment on that, but I'm just leaving it there as a question that I have. Because I think, yeah, go ahead.
So I guess what I meant to say, I guess if there was one of our esteemed academic institutions, which you all represent, and then there are others, if their pharmacology department was interested in drug development, that could be part of it. But we're not subsidizing work by Merck and Glasgow.
Okay, I see.
So that a pharma company cannot submit an RFA.
Okay, that helps explain, because we have a very well-known drug development group who I think would have an awful lot to contribute if you were to think about a more, translational program as opposed to a clinical program. And so that's the part I wasn't sure about on that one. If it ends up being more clinical in focus, then we would be less interested. But if there's a basic research component that we can add, or let me back up, a more translational component where we can use our drug development group, then we would be interested in that one as well.
So I'm open to other thoughts. My opinion would be I would be very open to translational research. I just would not be open to big pharma applying for RFAs because they have their own money.
Yeah, we understand.
May I add a comment? This is Art Levine.
Yes.
So if in fact, as part of this theme, we are exploring the genetics of how one responds with safety and efficacy to a given drug, and we hit upon a hitherto unknown genetic variant, it may well lead us to identifying even an existing drug that we haven't thought of before. For example, Mike Parmachuk knows well, but he has a faculty member with Castleman's disease. This is a remarkable story, the subject of a book about to come out, who in fact discovered the cause of his own disease and has not only seemingly cured himself of an otherwise lethal disease, but has had a huge impact on others with this rare disease as well. The point being that he used an off-the-shelf drug ordinarily used for organ transplantation to now cure a multicentric lymphoma. Mike, is that a correct
Yeah, that's as usual. I wish they had quoted you in the New York Times review of this book, but it's an amazing read, and he's an amazing kid, actually. He's a kid just for the group, just out of interest. This actually started when he was in medical school, and if you read the book or see him on TV, he literally was in the intensive care unit, given his last rites, almost dying 5 different times, and he just dedicated his life to it, and remarkably, with some resources and helps, identified a pathway, took an off-the-shelf drug that was already out there, and he's been in remission for 5 years. It's an incredible, but the kid actually is still doing full-time research, came right out of medical school to do it. He's very impressive.
So in any case, just to distill this, the fact of the matter is that there's nothing about a pharmacogenomics theme that would preclude us from the possibility of leading toward drug discovery and drug development.
That's very helpful. So maybe, Dr. Levine, you just elevated my interest in that particular theme. Either one of the two that we've discussed would be fine with Temple University.
Thank you. Dr. Parmacek.
Yeah, let me sort of take some off the table from my standpoint. First, I would agree with the comments relating to vaccine coverage. I mean, we know the science. It's a social policy issue, and it's a travesty, but it is what it is, and I don't think that's what I would support. I think that the pharmacogenomic priority I love and I favor, and I think a great deal will come of it. But then I'm stuck between two, and I'm going back and forth. Let me first talk about the aging priority. I really conceptually like the idea of studying the biology of aging. This has been a really tough thing to get your hands around, and it's very, very broad. There are companies, Calico being the leading company that's funded by Google, which was founded to do just this. And while a lot of their stuff is not public at this point in time, I do think that they are likely to make headroads there. It doesn't mean that we shouldn't do it in academia either. But I would say that writing this RFA, if we go with it, we have to be cautious. So for instance, are we going to accept proposals on Alzheimer's disease, prevention and/or therapy of Alzheimer's disease? That's not what I heard we want to do, and we've had that priority before recently. So we're going to have to exclude age-related diseases, but focus on the biology and pathology, if you will, of aging. And that gets into some pretty broad subjects like we heard about, like immunology and whatever. So getting our hands around that RFA, while I have a great deal of interest in it, I think will require some really critical thinking in terms of how we craft that RFA. The other area, which I think I haven't heard anyone support lately, is the cardiometabolic priority. And I am a cardiologist, and that's not why I'm supporting it. The reason I support it is because of the emerging science of nutrition. And I think that, we've all heard what the preferred diets are from the American Heart Association, and those things, while they change a little bit now and then, there's some real science now being introduced into nutritional science. And I think I heard some reference earlier on in terms of the way that nutrition alters the microbiome, or the microbiome alters the nutrients. There's a lot going forward. A question as simple as what is an ideal diet for a patient recovering from surgery? We struggle with that. And there are ways to measure that in ways we could never measure that before. Diabetes, we again have fallen back on most of the same dietary recommendations we've had for 25 years, but the science has not really, there are new scientific ways to look at what are idealized environments for, nutrition for diabetic patients. So from a nutritional science standpoint, focusing on that, I would be supportive of that amongst the priorities. And those are so I'm sort of struggling between the three. Actually, I love pharmacogenetics, and the other two I'm going back and forth in my mind on.
All right, so if you were going to pick two.
Oh, okay, you're going to make me do it, huh?
I am. I'm tough.
Yeah, that's all right. I'm taking pharmacogenomics as my first draft choice. My second, I am really on the fence. If we could craft the aging RFA to capture the biology and pathology of aging and those processes, and exclude research focused solely on aging-related disease prevention, and it's so hard to separate those, I would go with that. I just think it's going to be really, really hard to do it. So I'll throw that out as a challenge. I'll go with that as my second choice, but I think we have to be very critical about how we write that.
So Mike, this is Art. May I accept the challenge?
You may accept the challenge. Why am I not surprised?
So, Dr. Levine, this is Peter Tombros.
Yes.
I would just like to ask our scientists. It does seem to me that to Dr. Parmachek's point, writing the RFP for the geriatric type studies that have been presented here, I mean, it seems to me that if it's written appropriately, 3 of these particular studies could also apply. So I think how we craft that should be an opportunity to hit in a few areas and then end up trying to find the best kinds of research projects that in that broad space. Am I right about that, or is that just too broad?
This is Art again. No, I don't think that's too broad at all. I think it can be done. There's enough information already. Here I have to disclose a conflict of interest because I myself am the senior author of a paper which will soon appear exploring the genetic variants that account for looking old when we're young and looking young when we're old.
Good for you, Art.
So the point, only an old person could author such a paper. So the point I want to make is I think this can be done, and I'd like to have a shot at it if the committee agrees.
Thank you, Dr. Levine. Mr. Tombros, do you have your choices?
So I was just going to say that'll be one of my choices, and certainly pharmacogenomics is something that even I'm aware of. So I would vote for that.
Thank you. Senator?
I was struck by the fact that a lot of these presented the problems, but were very unclear as to what they thought was the solution. Having said that, I do understand, even though I'm intrigued by the vaccine issue, it's not a research issue. I've been torn between the two, the genes, environment, and age-related chronic diseases and the geroscience. There's a lot of similarities. I guess, can they ever be combined, or is that impossible?
I don't know if those two could be combined. One was more, I guess genes and chronic illnesses, possibly.
Age-related chronic illness, but they were age-related chronic disease.
Right.
Well, I would point out we did have a gene environment theme, I believe, in the past. And I did think, by the way, Dr. Levine, it was very helpful that you had laid out the timeline of all of the prior RFPs.
Thank you. So yes, we have had that in the not so distant past. So I have written those down so I can find it. We had gene environment interactions in 06-07. We had vaccine development in 06-07. We had autism in 08-09. Regenerative medicine in 07-08. Cancer in 11-12. Translational genomics in 11-12. So, for your information.
So, in other words, we're going to have to do one or the other. Okay. The age-related chronic disease, I do like that one. Since we did autism not too long ago, even though I think there's a lot more research needs to be done on that, then I would go with the testing on medication outcomes with the pharmacogenomic testing.
Okay. So finally for mine, so I've gone back and forth a lot. I actually, it won't get chosen, but I do think that the vaccine would be really interesting because of what we struggle with from a public health perspective. I think it would be different type of research. It would be public health research, behavioral science research. It's not bench research, or even specific clinical medicine research. So that would be one of mine. And in terms of the cancer, I'm just wondering about the cancer moonshot and the money coming through 21st Century Cures and whether that would be funding more of that. The pharmacogenetic testing would be my second. The geroscience I find fascinating. I guess I shared some of the other people's concerns about it maybe being very basic science in terms of aging, and we're looking for clinical outcomes. So I guess mine would be vaccines and pharmacogenetic testing. So I think that we can knock out some. So I think we're knocking out cardiometabolic diseases.
Yes, just a question. I just want to go back.
Yeah, further discussion.
Yeah, I know we're probably not going to pick it, but I think Mike Parmasak, and I'm a cardiologist as well, made some very important points about new science of nutrition and how important it is on a simplified level with if you will, impactful outcomes. So, I understand where the bandwagon's going here, but we should not forget about the opportunity of a simple topic that has a major impact on an awful lot of people with new science that can be applicable. So just a cry in the I'm the single tree in the forest. I just wanted to bring that up.
So Dr. Davis, that was part of my question, though. It appears to me that could be included in the way in one of the two that we're talking about now is geriatric medicine.
I'm not saying that.
Yeah, it may be tough. I think it may be tough to do that with the amount of money that we have in terms of splitting the topic. Is my concern.
Would you like to change your vote?
Yeah, I'll.
You'll vote for that.
I'll vote for the nutrition for medical science for me
instead of
my second one, which was cancer.
Okay.
Dr. Levine, our chairperson, if I could just make a suggestion.
Sure.
I think to use Derek's expression, you can see where the train is going generally. I'd like to suggest that for those that we're struggling with, particularly the first one, prevention and management of cardiometabolic disease, and clearly there was a big focus on nutrition, and those points are so important in so many populations and subpopulations. I would suggest that if it is not a selection in this go-around, that we reconsider it in the next go-around.
Sure. That's fine.
Well, Dr. Levine, this is Peter again, wouldn't that still qualify for what we're talking about? I mean, Dr. Parmachek's point about trying to broaden it in a way that would let three of our proposals still fit in.
Well, so that's one question that the committee has to decide. In the past, long time ago, there were two. You would choose two priorities. In the last number of years, the committee has chosen one, and there's the money is about 11 million plus. 11 million. 11 million plus would be the funding. And I worry that if you have more than one priority, you're not going to be giving that much money. So, if you have, usually we have chosen three winners. Is that correct? 2 to 3 winners?
Yeah, because it's $4 million.
So they would get somewhere between 3.5 and 4 million apiece. If you have two categories and 2 or 3 winners apiece, now you're talking about $1 or $2 million, which doesn't go as far as it used to. So in the last...
I'm not articulating this, I think, properly. I'm not advocating that we expand the number of choices. It just struck me that besides the pharmacogenomics, when you talk about aging and you talk about looking at geriatric medicine, it seemed to me that the number one study, which I really think is powerful, could still apply for those monies.
So I'm going to ask Dr. Art Levine to comment on that, because you are the person that has proposed the geroscience.
Well, once again, the notion that I want to propose to my colleagues is that the one area that we haven't touched upon at all, as you look through the list of themes that have been supported earlier, is the biology of aging. And everything we're talking about here really does relate to the fact that most of our health burden and the healthcare economy burden occurs as we become older. And therefore, our ultimate goal ought to be to try to understand whether we can get enough insight into this broad spectrum of aging biology such that we can help people to have better lives, not to live longer, but to improve the quality of their lives. And if we can do that, then we can regard cancer, Alzheimer's, cardiovascular disease at all as secondary to the insight we gain with regard to the biology of aging. And if we're going to go with only one theme, we might even want to think about how our sensitivity and susceptibility to drugs, their safety and efficacy, may change as we age, again, as a consequence of the biology of aging.
So this is Dr. O'Donnell. Just a quick question. Are we choosing one or two?
Well, I think that's up to the committee. In the last number of years, we have chosen one: Alzheimer's, opioids, traumatic brain injury, healthcare innovation, primarily big data. The CBD was added, but in the years past, starting around 2000, for 12, there were usually two choices. I'm just saying that if you have two topics, and each topic has 2 or 3 winners, and there's a total of less than $12 million that we're distributing. Depends on, it's not just my decision, it depends on how much money you want to give the winners, right? So do you want to give them almost 4, or do you want to give them less than 2? That's the question.
Right.
So if you're going to give them 3.5 to 4, my recommendation would be pick one topic. If you're content with giving 3 winners essentially $1.5 million, that's less research, but that can be done. It's really up to the committee.
And Dr. Levine, I'm sorry, just one more minor clarification. When you say 3 winners, are we picking a number of winners in each topic, or are we choosing one winner in each topic?
Well, in the past, there have been, this year, so for opioids, there were 3 winners under opioids. Under TBI, there were 3 winners. Under healthcare innovation, 1 winner.
They were done together, but with 2 years of funding.
All right. For big data, 3. So again, that depends on the quality of the proposals and how they're chosen.
This is Michelle from Temple. I strongly would urge my colleagues that one theme is the best way to go for a number of practical reasons, along with what I think are perhaps some reasons that pertain to the public interest. From a practical standpoint, as we all know, the actual implementation of this program, it takes a lot of time and effort to get people to get their proposals together out of the door, and doing that times 2 themes is substantially harder than it is to do it times 1 theme. And I think it affects the quality of the proposals, because everybody ends up kind of hedging their bets. And so we would have, I'm sure you all have the same thing at your home institutions. You can tell me if I'm wrong. the same people who would apply to theme 1 would apply to theme 2, many of them. And so then instead of getting, a better quality proposal on a more defined theme, you're going to get everybody sort of scrambling to try to respond to both. But I also think that the public's interest is better served by having the state invest in a deeper dive on a particular topic that 3 different teams are approaching, obviously in different ways. Because I think what we get out of it as Pennsylvania is, you now have essentially seeded 3 cohorts of researchers who are doing work. You have a better chance of covering this data as a whole by doing that. So just from a programmatic standpoint, I'm with you, Dr. Levine, but those are the reasons why I'm with you on that particular recommendation.
So for that, I just worry that if we spread no matter what I can do, you're going to have approximately 11 point something million dollars. So it depends on how you want to cut the pie, but in this day and age, $1.4 million is not going to go all that far, and so I worry that it won't produce the results that we want to produce. And so if you double or more than double the money, so my recommendation, although it's not my decision, it's the committee's decision, would be to go with one choice.
So if I could just pick up on that, I agree that based on everything that Dr. Masucci and others have said, I think and you, Madam Secretary, I think we should go with one. I think it should be the geroscience approach. I take Mike Parmachek's words seriously, and I get where he's going with this. It can't be disease specific. It's got to reach. It's got to dig deep and look at a very biological level. What are the phenomena of aging that drive diseases across a disease age spectrum? And I have confidence, especially after Dr. Levine told us what he's working on, that he can put something together. I would also urge that we not try to do combinations. I think it's pretzel twisting, trying to fit things in that don't really fit in. So I'm comfortable with going with one, with going with that topic, with ensuring that it's written in such a way that we're going to get the kinds of proposals that we want that are not disease specific, but rather biologically focused, and deliver the deep dive that Dr. Masucci mentions, and produces some real value. And especially given the fact that the Commonwealth it's either the top or one of the top aging states in the country. I think it's a good investment.
So if I might distill our discussion, it seems that there are 2 topics that have risen to the top: the geroscience and the pharmacogenetic testing. And so if we're going to pick one, we need to vote between those 2. Does anybody have a problem with taking those 2 out of bringing those to the top of the list and then doing a vote? Does anybody want to do anything differently? Dwight?
I'm in favor.
Is everybody okay? Anybody that's opposed of taking those 2 topics out and then doing a vote, let me know. Because they seem to be the ones that everyone seems to be talking about, and the others, although very excellent goals, seem to have fallen a little bit to the wayside, although it's hard to say I don't support cardiometabolic disease research, but of course we support that. But in terms of this voting, does everyone agree that we're going to do one topic and those are the 2 top vote getters? Great.
Agree.
Okay.
Agree.
So let's go reverse. Pat Vance, which choice would you make? Senator.
I think the unlocking the secrets of aging.
Okay. Mr. Tombros.
Yes, so I would go with the same, no problem. But again, I don't understand why the cardiovascular study wouldn't fall into that.
Well, that would be up to, I guess, probably Dr. Art Levine in terms of how he writes up his proposal.
Exactly. And so I thought I heard that it could be done.
Well, once again, I think the challenge here is for us to gain insight into what happens to us as we get older that makes it increasingly likely for us to develop cardiovascular disease, Alzheimer's, cancer at all. But the fundamental issue is not those diseases per se. It's the process by which we age to begin with, and why that changes so much between different members of our species. Why is it harder for minorities than for whites? Why may it be harder for people in rural areas rather than urban areas? Why does it differ from one culture to another, one ethnicity to another? These are all questions that relate to the fundamental biology of aging and how the environment and our genes play on that biology. So I wouldn't exclude anything.
Yeah. Okay. I will. I think I understand.
So you're voting for geroscience?
Yes.
All right. And next we have Dr. Parmacek.
So my concerns still relate to the actual wording of this thing, but I actually, listening to what Art just said, my even greater concern is how a review panel is going to be able to cover the breadth of what might roll in if we go with geroaging. But that will be their issue, I guess. But it will be a challenging issue because some of those things that Art just described are in very, very different fields and will require different expertise. That being said, it is sort of more intriguing, and we do have a lot of elderly individuals in the Commonwealth of Pennsylvania, I think amongst the highest in the country.
And on the committee also.
What's that?
I said on the committee also.
I wasn't going to go there, Art. Anyway, I was specific. When you said you were conflicted, I didn't know where you were going with that one. That being said, so I guess I'll go with it, though I do think we should look very carefully at Art's draft of this thing and have, perhaps if there's concerns following that we have a quick follow-up either via conference call or email to clean it up if people have concerns.
Fair enough. Dr. O'Donnell.
I agree with everything that Mike just said. I think that it will be challenging. I think that Art will meet and manage the challenge. And I do think it's a good idea to come back and revisit the written draft, which we always do anyway. So I think we're headed in the right direction on this.
Thank you. Dr. Masucci.
Well, my vote is for the pharmacogenomic project, but I'm very supportive of this other direction if that's what we all decide. I just think that there's really innovative science to be had in that topic, and the prospect of all of us kind of devoting resources to that topic, I think, would yield some very important outcomes on a practical and translational level. So I'm going to give that one the edge, but I have confidence in Dr. Levine to be able to help us get the RFP correct if we decide to go with the age-related chronic diseases topic.
Thank you. Dr. Arthur Levine.
I don't have any comment other than that I need to know what the deadline will be for me.
Well, which one do you vote for, sir? We're not done yet. Do you vote for geroscience or pharmacogenomics?
Well, I prefer to call it the biology of aging than geroscience, but yes, that's what I would vote for.
Okay. And Dr. Davis?
I have been beaten into submission. I will go with geroscience.
All right. Dr. Davis goes with geroscience. I will go with geroscience, so geroscience wins. There you go.
And if I could just...
What's my deadline?
Tomorrow. Penny, what's the deadline?
I would say, how long does he feel he needs?
How long do you need, Dr. Levine?
Well, I'd like to have a month if I can have it.
You have them on. Very good. Someone else had a comment?
I was just going to mention that I thought, never mind. I think we covered it. I just have confidence that that Dr. Levine's going to produce something that is going to work and will satisfy a lot of the things that we've talked about.
Thank you.
Thank you.
Oh, and
I think we all share that confidence. Excuse me?
I liked Art's title better.
I do too. Okay. Biology of Aging.
The Biology of Aging. I thought that was a much better title.
He's right.
Yeah, I agree.
It's the title.
So, Dr. Levine, I have one side issue that came up earlier that I feel I need to mention, and that is, would no commercial companies be eligible to apply for these grants? I think, depending on that, I think some of our legislators might be disappointed that we were excluding research being done in small Pennsylvania startups.
Well, that's an interesting question. I'm looking to our attorney.
Well, I mean, the statute provides exactly who is eligible as far as institutions.
What does it say?
Nonprofits in Pennsylvania, institutions of higher nonprofits in Pennsylvania that do research, institutions of higher learning, and I think there's a third one. Looking for this. Yes, and then the establishments under the County Municipal Health Department. Established under the
Did you all hear that? It's in the act, sir.
Yes. So that rules out. I couldn't hear it very clearly, so I just need a yes or no.
The answer is no, sir.
If I could please weigh in on this, this is Dr. O'Donnell. In the earliest days of this board, and I would ask council to just maybe go back and look at the original legislation and whether or not there were any amendments that changed the original legislation to eliminate the prospect of startups and companies applying. We did have companies applying. There was one instance very early on in which a company was funded, but there was only one instance that I can recall in my earlier tenure on this board. But I do believe, to Peter's very good point, that there are members of the legislature that are looking to see something happen along these lines. And so unless there was an amendment to the original legislation that prohibits companies from applying, I believe that companies are permitted to apply. And I do remember one such company actually getting an award. I don't remember when but it was a long, long time ago.
And that is true, and some still do. They are required to be nonprofit entities that do research.
No, I was actually speaking of for-profit entities that are
Should not do that.
Well, I'm just pointing out that it did happen, and whether or not that's changed is something for council to determine, I think.
But we will.
I can speak that now.
Yeah, I thought it was because we had at one point the dual track and there was a commercialization theme that particular year, which was the only time we've ever had that, if I recall correctly.
With a non-formula commercialization.
Correct.
Once. Can you read from the act?
Yeah, that's what I'm doing. Institutions are defined as nonprofit entity that conducts research, a hospital that conducts research established under the Healthcare Facilities Act, an institution of higher education that conducts research. They are the institutions that are eligible for funding under the statute. And again, also the local county municipal organization created under Act 315, or a person is the other part. But as far as for-profit entities,
I think it was for a person. I think that's where it landed.
Okay, then if that is fell within that category, then that's within the confines of the statute. Yes.
Right.
I don't remember that one specifically, but Penny seems to.
Sounds like a for-profit company cannot apply.
That is correct.
So I guess if you strongly disagree, then give us an email and we'll review it.
I'm happy to send an email. I would also just point out that institutions of higher learning, including all of our institutions, are all starting for-profit companies or developing things that potentially have a commercialization aspect. So there's a crossover there as well.
Right, but your academic institutions themselves are not for profit. They might spin off a for-profit company, but they are not for profit.
Quite right. Yes, agreed.
I think that's my gut is that's inherently different. If Pitt or Penn or Penn State or Temple spins off or Jefferson spins off a for-profit company, this does. But Pitt and Penn State and Penn and Temple and Jefferson and I don't know are all still not-for-profit academic institutions. I think that's different than Merck applying. A small for-profit, in that area, that seed area of Pittsburgh. It's still a for-profit company. So my gut is no. That seems to be what the legislation says. Although, if you feel different, then send us an email and we'll look at it.
Okay, sounds like a plan.
Great.
So, Dr. Levine, I agree. It sounds like the answer is no. I just want to make you aware that there are a lot of legislators who don't realize that. So in some way, or I think it would just be good to make sure they know that so they don't waste their time trying to get funding through this mechanism.
Also, now, of course, the legislature can always change the act, right? There's an act of the legislature, so if they feel that strongly about it, they can change the act.
Well, of course, I just wanted them. See, some of them have these small companies in their jurisdictions, and they're, looking for ways to help them get funding. So a lot of them point to this program.
Yep. And that has come up before, where we have had for-profit companies come to legislators and even the governor's office looking for cures money, and the answer has been no, that they have to find their funding in a different manner, but that they can't do it through the cures funding. And so we have actually told a number of different political bodies that point.
Excellent. Thank you.
We appreciate, Dr. Levine, that you have done that. I think it's important to point out, that last year when there was legislation to create the spinal cord carve-out from the PA Cure non-formula allocation, many of us pointed out the concerns that we have about whittling away at what's already not a very large pool of dollars to support research. There's very little investment in research from the state budget. And of course, PA Cure dollars are pass-through dollars. They're not really state dollars either. So I would just make a pitch for doing our very best to keep focused on what the goal of this source of funding is as a basis for supporting Pennsylvania being able to have a small resource, relatively speaking, to maintain its prominence in biomedical research and position it to be able to go grab those federal dollars that, of course, we're always chasing. Not to say that I don't believe in commercialization. I mean, I run commercialization at my university, so I normally would be a very big advocate for that. But we really do value that this program exists as it's currently structured.
I agree 100%. And again, as we notice any rumblings in the legislature about anything that has to do with cures, we will let you know. Thank you. Wow. Well, we are doing really well. Yes, Dr. Davis.
Before we adjourn, I just want to remind everyone, and I think most of you are on the call, but there is a concern about the timing for submission for the formulary funds.
Yes.
And my understanding is that that date has been significantly moved forward from the past. Is that not correct?
Well, it's early this year.
Yes. Was there a reason why
we found out the budget early?
Okay, but what has happened is that we put some institutions in an awkward situation because they were not expecting an earlier date, and now they're going to have to put their information together in a very, very short period of time. So I would just request that we address that shortly, and if there is any leeway at all for us to allow them a little bit more time, we should think about that.
And was it Dr. Masucci? Yes. Is it Dr. Masucci? Is that what you're referring to? The date in terms of formula funds?
Well, it's the combination of two things together. It's both the sort of bringing forward the timeline to September 24th for the date, as well as the fact that what we were told at the public meeting is that there will be no opportunity to revise your request if one of the projects is rejected, and that lies to the heart of our concern. We really don't have transparency as to why the projects we submit are or are not, accepted in the first place, and so it means that we're retracting. Now, we have many projects lined up. We'll make the deadline, but it is really changing our strategy for what we put forward into a no-risk strategy. But that means that you may not be using these dollars to stimulate kind of new investigators and, more cutting-edge kinds of studies. And that would concern me a great deal, because what you're going to get from us is going to be, our top folks who are already very well funded, but we have to be sure that we're not going to be told, no, you can't use the dollars. And so it's the combination of that's putting an incredible amount of stress on us to figure this out, and I don't think we're alone in that.
Thank you, Dr. Masucci. I know we were going back and forth in an email just moments ago. I think I understand the concerns, and the team understands the concerns too. Let's talk at 1:30 that we're scheduled to today.
I can address it now.
Well, I think I would actually, why don't you fully discuss it offline so that we understand have a little bit of chance, not at the end of this meeting, to fully understand it, and then we will send an email out to everybody. Now, let me ask you a question, because we had talked about deadlines. So the deadline was set when?
August. It went out August 1st, the request. So it's 2 months.
So the deadline, August 1st to September 24th. 27th.
Yes. Whatever the Friday is. Is it the 24th? It's the 27th.
It's the 27th, but we'll call it.
No, that's not true anymore. It's the 27th.
Yeah.
What?
It can be received at the facility. Yes, that was in the response to the question. Yes.
So I gather the date is the 27th, yes. Dr. Masucci?
It's the 27th.
We're not asking for more time at the 27th. What we are simultaneously we're also simultaneously. Okay, well then this is broader than just me. It's a combination of the 27th, because yes, the RFP was released, but remember, then there was a Q&A, then we had to wait some more time to get a response to the Q&A. Then we've been back and forth trying ever since August 20th, trying to get additional questions answered. We don't have any feedback at all. So it's,
who did you
the timeline, but
and you were trying to get those questions answered.
I'll send you offline a list of all the questions, of the times that we attempted. We have a record of that. I'll send it offline.
Thank you.
But my point is so with no information all the way to today on some of the core questions that we have, we really have had a strategy internally, to, approach this fundamentally differently than we have in the past. And then it's my understanding from the Q&A responses, without any clarification, that if when we submit them, one of the projects isn't accepted, then we just lose that funding. And that is what's provoking widespread at my institution deep concern.
Penny is saying no.
No, it's after the grant agreement is signed, not during the review process.
I don't even know what that means.
So
what
you're
does that
going to
mean?
talk offline.
Okay, that's fine. All right.
That offline conversation.
Well, that's where our concern comes from.
And we will email to the whole group the results of that in terms of so everybody understands.
And by the way, we would not be opposed to an extension of the deadline. If that helps others, it would certainly help us too.
So so we've been talking about deadlines. So Penny, since everything is earlier this year, if we extended the deadline a week or 1 to 2 weeks, would that negatively impact the program?
Well, the issue is you've received the timeline, and we're trying to get things done earlier.
Right.
But it'll delay. So it's delayed.
It'll delay everything, but it won't break the bank. But we have that gets back to our question before, and so would people? I guess would you be looking for 1 or 2 weeks?
2 weeks.
2 weeks. So what date would that be? Well, October 11th. You got it? Okay. So I'm going to ask for a motion and a second and a vote on this so that there's no question about the timeline. May I have a motion to extend the timeline 2 weeks to October 11th?
Dr. Dwight Davis, so moved.
May I have a second?
Second.
Who was first on the second?
Art Levine.
So we have a motion and a second. May I have discussion about extending the deadline 2 weeks? You realize it puts the whole program back 2 weeks, but it won't break the bank, so it can be done. Do I have discussion?
If we could just clarify the date, I think that would be helpful.
October 11th.
Thank you.
I'm in favor.
Does anybody feel that that's unfair to people who have been working on that deadline?
So I assume that everyone will be informed that we have.
Everybody will be informed.
So everyone will be in the same area.
Absolutely.
Okay.
So not just the institutions that are represented here, but Penny, everybody will be informed that we're giving an extension of the deadline. Any discussion?
And just to clarify, the extension of this deadline is to whom and for what purpose? Is it related to the work that we just did on selecting the price? Okay.
No, this is for the formula funded
2019.
Oh, okay. All right. Thank you. Thank you very much for clarifying.
That's what we're talking about.
Got it. Okay.
All right. All in favor say aye.
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 Any opposed? Any abstentions? So let it be done.
Okay.
So we have extended the timeline for 2 weeks to October 11th for this formula funding. But Dr. Masucci, Meghna and Penny will talk with you offline about that issue, but the other issue, and then we will send it out to everybody about clarify those points.
Thank you. I cannot thank you enough. Thank you so much.
Great. Well, so I think that was a successful meeting, and we're even finishing about 10 minutes sooner. So I think that's pretty good. Thank you all so much for your engagement here in this. It is so important. Coming from academic medicine myself, I understand the importance. There's nothing more important in terms of our functions at the Department of Health, which are considerable. But stimulating and working towards funding medical research and academic research. Our next meeting will be scheduled for January 2020. We will send you the dates. I would love to have you here, but realize that the weather doesn't always cooperate, so the phone is fine, even for Dr. Davis, who did come here. It should be noted. Is there any other business before we adjourn? May I have a motion to adjourn?
So moved.
Dr. Davis, second.
Second, Michelle.
Okay, Dr. Masucci, thank you. All in favor say aye.
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 Any opposed? Any abstentions? Thank you all. Bye.
Thank you.
Thanks, everyone. Bye.
Bye.